same what we are decompressing in the thecal sac and traversing nerve root, and possible we can do contralateral exiting nerve root decompression also in some time patient and exiting stenosis also. Again, para UBE we do exiting extra foraminal and foraminal stenosis. We deal with para UBE, and in the last UBE fusion. So today we'll cover just the basic about UBE, what is the UBE and how we do and what are the principle of our unilateral biportal decompression. So nowadays, initially we have taught that whenever the surgeon, if the surgeon is very big, then he put the big incision. But nowadays it's not like that. If the surgeon is good enough in spine surgery, he has a good skill, he can gradually decrease his incision side and can do with small keyhole surgery. So what is the biportal endoscopy? It's basically arthroscopy. What we do in knee and shoulder arthroscopy, it is similar to more of near to the knee arthroscopy, because here we mostly utilize two ports. One port is for scope and other port is for our instruments. So it's basically like the same what we do in open surgery. Only difference is we are working inside the skin and subcutaneous tissue and muscles. So all the instruments which we are using for the open surgery are we are using in UB surgery. Only few instruments which need to be addressed. Most important thing is triangulation. You have to have match your scopic portal and working portal. You have to see freely your scope instrument with your scope, and first your target is spinal or minor junction. So what are the operative preparation? Usually we do under general anesthesia or epidural anesthesia. I prefer epidural. Prone position, same what we are doing in microdiscectomy. Nowadays there are special drape available with fluid collecting bag, so you need not to use your previous drape. CM radiography is very essential because everything we are doing inside the skin and muscles. So CM everything under radiographic visualization. So these are the initial preparation. If you don't have any fluid collecting bag, what I do, I use that tracheostomy tube and that Bain circuit, and make it curve towards on surgeon side, tilt the table towards surgeon side, and we use IOBAN so that all the fluid which are collecting, it just goes just behind collecting bag, which is we kept just in the floor. Usually here we are majority of surgeons are right-sided surgeons, so we usually start on the left side of the patient, because our scopic portal, working portal, we are very handy with using the right hand and right instruments, and you hold the scope with the left hand. So what are the basic equipments we need? We need the endoscopic system, 0 degree or 30 degree, 4 mm telescope. 0 degree is for decompression. If you are very good with 0 degree, you can switch to the 30 degree, because 30 degree will give more view, and when you want to do contralateral decompression, then 30 degree is more helpful. Arthro shaver, we need a striker burr system. I think all the institute have striker burr system, so 4.5 mm burr system is enough. And initially, if you are a good surgeon, then once you have done good surgery, you can also use that acromion burr also, because it increase your speed of burring. RF system, same what we use in nowadays available with MyTech, Bones and Arthrex system. Irrigation system, same with what we use in interlaminar and transforaminal system. And some specialized UBE equipment we will show you in our live surgery. 2 mm Carrison punch. Preferably if you have a rotatory punch, it's good. Otherwise, your normal Carrison punch can work well. And general spine surgery instrument. Second, what is the difference between UBE and arthroscopy? What are the fundamental difference? Initial working space we have to create in UBE, because there is no space. All is filled by muscles and ligaments and soft tissue. In joint cavity, once you enter inside the joint capsule, you start saline flow, your joint cavity will swell. So you automatically get a good working space. But here you don't have any working space, so you have to create your working space. Depth is much deeper than joint, because joint are subcutaneous. Size of working space is around 1 to 2 centimeter. In joint, you have entire joint. Here, dura, nerve and cord are the dangerous tissue. Hydrostatic pressure, if you give too much pressure, that can influence the CSF also. Patient might have neck pain and convulsions sometimes. Bleeding control, here meticulous bleeding control is very important. most time tourniquet, so bleeding control is not that much important, but yes, in shoulder it is very important. But in spine, bleeding control is very important, because once it start bleeding, then your entire field become messy and you cannot see anything further. Yeah, low temperature burn. If you use too much RF, then there might be a skin blisters happens in UV patient also. So what are the working principle? Here the multifidus triangle. It is a triangular muscle. You can see here. So there is a potential space below the multifidus triangle. So you can utilize that space and create the initial working space between two multifidus muscles. So you can see here, there is a potential space. In a CT scan image you can see. This scan you just swell up with the saline and connect the two ports with this multifidus triangle. So what are the key points? First is important skin entry. Skin entry is very important. Second is initial target and working space creation. Third is irrigation system. Fourth is bleeding control and scope and instrument handling. So initial skin target point, here you can see in lateral, if you see that the bump of the lamina. Here you can see the center of bump of lamina is very important landmark in the lateral. You can draw the line, extend it further anteriorly. It can come up to the upper part of the vertebral body, and you can mark as a midline and 1.5 centimeter up and 1.5 centimeter down. In the lateral view, if you see, it midpoint between the spinous process and facet joint. So initial target point is spinal-lamina junction. So nowadays with ease, what I used to do, I take lower pedicle as a scopic portal and mid pedicle of the lower vertebra as a working portal, and create medial border of the pedicle. Medial border of the pedicle is entry point over, and we just need to target these 2 points. This is the lower part of the pedicle for a scopic portal. Mid pedicle of lower vertebra is a working portal, and medial end of pedicle both. You just start taking entry, take horizontal entry, facial entry, little oblique inside, so that your scope, all the instruments are going obliquely towards the spinal-lamina junction. So your initial target has to be there. This is a spinal-lamina junction. So your initial target has to be there, and just fill with your initial dilator. So when initially we use the needle technique, we keep the needle and one dilator, and we see in the C-arm. You see here, there is a spinal-lamina junction, needle and dilator both are merging towards that junction, and then we create the space. This is how we create the space, you know. Yeah, you move unidirectional and try to touch the both instrument together, and again little bit horizontal movement also. Then put the scope. Initially I use this shoulder obturator because it allows us to retract the soft tissue in the scopic portal also, and I also use shoulder obturator in working portal also. So now first is your free flow of the water. So now you see the water flow has come. You see now in the video that there is spinal-lamina junction. You can see the lamina and part of spinous process. There is junction of spinal-lamina. So initial this entry point and this target initial visualization is very important. Once you get this initial visualization, then your surgery is relatively easy. This is for paraspinal approach. In paraspinal, you just target the foramen in lateral, take the center of the foramen and go 1.5 centimeter up and 1.5 centimeter down. Don't congest two port very near, because your instrument handling will be very difficult. In the AP, you need to go 1 centimeter from the vertebral body, and foramen, take the foramen in the center and half up, half it down. So flow of the irrigating saline is very important. Your scopic port will give you the saline, and it has to come out from the working port. So according to it has to create inside, it has to go inside the space and create some elevate the muscle and create some working space and then come out. So it works like Bernoulli mechanism. So irrigate. Triangulating the things. So with initial we have L kind of retractor, small thin blade retractor. You can ask your assistant to hold that retractor. Working flow will continue. Again, if you have good arthroscopy team in your hospital, they have shoulder obturator system. You can use that. Nowadays, again, UB special retractor is also available with Manman. You can ask. It's a semicircular kind of retractor. According to depth of the patient's back muscle, this is available in different sizes, 40, 50, 60, 70 millimeter. And hydrostatic pressure controlled by the outflow. Bleeding control is most important because here we don't use tourniquet, we don't have anything direct system, because once bleeding start, then muscle bleeding starts from occult space, then very difficult to identify. So wherever you find some bleeder, try to coagulate them. Don't allow it to become more larger. Hydrostatic pressure of fluid is very important. Sometimes increase the height of the bag. This saline NS bottle height, you can increase the height, and sometimes you can control. Put the one 3 liter bottle, 1 ampule of epinephrine is also sometimes helpful. But again, with epinephrine, just monitor the blood pressure. Sometimes it may shoot up. Systolic blood pressure, ask our anesthetist to keep systolic blood pressure below 100. And direct coagulation with RF is very important, and identification of bleeder. And all the bleeder corner in every part. You have seen one figure. There is at the spinal minor junction, when you just ligamentum flavum is bifid ligamentum flavum. At that time, you just good coagulation. You just control the good radio frequency. With radio frequency, good control, good epidural bleeder. Then when the corner in the facet junction, up and down, these 6 corners are very important for bleeding control. So scope and instrument handling, track of the working portal, specialized instrument guider. So because every time you have to have a smooth track. Once if your instrument handling is not good and your track is not become properly, it made properly, then you might injure the lumbar fascia and muscle and all this, and every time this soft tissue coming in the way, and you cannot get good retraction. And every time smooth insertion of instrument is very important. Again, unidirectional drilling. You use the striker drill system or whatever drill system. If you are unidirectional, it has to be unidirectional, and it has to be gradual. It should not be haphazard. You have to follow the principle of the drilling, and everything is under vision. It should not be a blind surgery anytime at any moment. If you can't see, wait for a few minutes. Ask your anesthetist to reduce the blood pressure and just try to get more clear view, but don't go blindly. Complication is same with open surgery, dural tear, infection, but it's very rare. Sometimes synovial cyst happen, low temperature skin burn, recurrence. So this is the initial case. You can see L4-5 stenosis with right-sided disc. So this is ipsilateral side, and this one is contralateral side, and it is a right side disc. So we are this is my shoulder arthroscopy obturator. We just retract the disc, and now with RF we will remove this disc bump. You can see with RF, because it was hard disc, not a soft disc. Any problem? The post-op of the same patient, and again with left side huge disc herniation and with stenosis. Here I just want to show you that how we drill. This is very important. You just feel the bone and start drilling from spinal minor. Here is the spinal minor junction, and start drilling. Go down, down, down till facet joint. Remove the medial most part of the facet, and it's flow like this, oscillation type kind. Go till down till the flaval junction with the lamina. Again come up, gradually moving down. Again come up. And any kind of bleeder, just with this RF ablation mode, you can control the bleeder also, bone bleeder also. This is a very good advantage of UBE. You see, now we created a space. So now we identify the midline. Identification of midline is very important. Where the flavum is, you can see the cleft in the flavum, the one bleeder is there here. It's again very important to control that bleeding. This is on contralateral side. So we are controlling that bleeder. So this is, we are removing flavum on opposite side. This is a shoulder obturator, you see. With that obturator, we retract the nerve root, and so our neural tissue is now we can freely go on opposite side and decompress the nerve root. So this is how we detach the flavum with RF, and if you have a curate, angle curate 90 degree, then it's also very useful. So 2 millimeter Carrison punch is very important. If you are doing fusion surgery, then sometimes you use the 3 millimeter, but most of the time 2 millimeter is more than enough. This is post-op MRI of same patient. So again, yeah, the initial learning curve is little steep, but once you have, you all are aware of endoscopic system. So we all have kind of triangulation, awareness of triangulation. So we can easily start UB and can see. The second thing is always listen to your masters. So you who have done good amount of endoscopy and UB and interlaminar, which will shorten your learning curve. So initial complication, what they have faced, you can overcome that complication. Never give up. All the best. Yeah. Thank you.
A slight change in plan. Next talk will be by Dr. Shiraj Munshi. He'll be talking about percutaneous stethoscopic lumbar decompression. Now the idea is he'll finish the talk first so that you have a fair idea of what the surgery is going to be. Then he will be proceeding to Brindavan Hospital to start the surgery. Okay. Welcome, Shiraj. Dr. Shiraj, as you know, is a multifaceted personality, and he has, I think, he has done his orthopedics at a much later stage, out of motivation basically, and along with that, he has been very instrumental in bringing out good instruments, good quality, and different designs which you don't find normally. Like yesterday, you had heard Dr. Sukumar commenting about in one instrument, which even Dr. Mahesh also. So it has helped us. It has helped our surgery, and he has recently moved on to performing even PSLD surgeries also. So he'll be demonstrating one surgery today, and even the cadaver in the evening as well. Over to you, Shiraj.
Thank you, Ravindra, for inviting me here. Now, we all know that initially endoscopy we started with doing all the transforaminal, and after having many transforaminal, we realized that there is something lacking, and then we move ahead with the some different technique also. So basically, we have done enough the endoscopy work. So now even we are at the stage to conclude something that for one particular patient you have the best indication that you have the all the options available, and out of all the options what you need to do. And since I'm into industry also, so I realize there is a big confusion going on in everyone's mind that what to do for what. So I will just try to make it my experience that what I do for my patient, and then it can help you to choose the case. So first of all, we exactly don't know that what is the difference between the internal laminar endoscopy and the stenotic decompression. So basically, both are same. In interlaminar endoscopy, you just dock on the site and you just cut the phlegm, and basically with the interlaminar endoscopy, you are doing more of a discectomy. But in stenotic decompression, you have to remove the full stenotic area. So you have to dock on the upper spinolaminar junction or on the facet, depend upon the site, or you want to do unilateral or bilateral decompression, and then you start drilling the lamina, you expose the ligamentum flavum, and then you just try to remove the flavum as a whole. So like you start with the upper part, then you come lateral, you separate the flavum on the inferior side, then you detach the flavum. So like here we don't cut the flavum, and we specifically say that we don't need to cut the flavum because in stenosis the flavum is very thick and it will take a lot of time. But if you detach, you can remove most of the time flavum in good number of pieces, and your job is quite comfortable in stenosis. And then you work on the facet, you work on the SAP, and you go from the inside. And the good thing is you can do the same work on the opposite side with the same incision. So the over the top contralateral decompression is also very much possible. Now again the other thing is about doing the UBE. So I have seen that there is a big confusion about UBE and the PSLD. So I can say both are exactly same. The surgery, the end point is almost same. The only thing is that PSLD is having the very good advantage in terms of two things. One is the muscle trauma is quite less in PSLD as compared to UBE. The second thing is we have the established irrigation channel. So because of this irrigation channel, all the issues related to fluid is not there, or it's very less with PSLD, because see what happens even the big expert or our masters, they don't speak about the complication until you become very close to them, and then what happens that you start doing the case and then you realize. So like one most important example I want to give you. one of my Korean colleague, he said that in UB, my anesthetic is not good. Always my patients post-operatively, they don't wake up, and sometimes we have to keep the patient for 12 hours or 24 hours for in the ICU, or they're just sleepy, and I don't know. So, and see, like I do have the anesthesia background also, so I realized that this is not the something related to the overdose of anesthesia, because we know that now the most of the anesthetic medication, they are very short acting, and you don't it don't take long time for the patient to wake up. So there are two most important things which we have to be very careful. One is the fluid pressure. So because of the fluid pressure, two things can happen. One is the dilutional hyponatremia. So what happens, your fluid will, if you have the high pressure, or if your outflow is not very good, so the fluid is going to go inside, it's going to build up the pressure, so it's going to absorb through the venous channel, and this absorption of the fluid, it can lead to the dilutional hyponatremia, and it has a effect on the CNS, because it will swell the brain. And so it's like what happens in the TURP, the same thing can happen here, and it happens a lot. So to overcome, so this is the one thing. The second thing is the patient will have the increase in the epidural pressure, because you see, once you are doing, the fluid will go to the epidural space and it can go up. So because of this, the epidural pressure is going to go high, and it's going to compress the cord. And if your patient's position is not good, the fluid can go up to high into the neck. So what happens, like what is the difference? Like, I do most of my surgery under local anesthesia. So what is the advantage? Like, my patient can tell me if they have any issue, and we are been doing this under local anesthesia very regularly, and we have done enough cases also. So what happened, after some time, immediately patient will tell you, "Oh doc, I'm not comfortable, my shoulders are aching," and so immediately after 1 hour, 1.5 half hour of the surgery, the patient will become little uncomfortable. So this is exactly the point where you have to be very careful, because if you don't be careful here, immediately your patient can convulse, because this is related to the fluid pressure. The moment you stop the fluid, you change the patient position, wait for 5 minutes, all the symptoms will disappear. But if you continue, then definitely in next few minutes your patient is going to convulse. So what happens, that anesthesia doesn't prevent this, it just masks this kind of issue, and that is what the people have the issue, and they really even don't know. They put the blame on the anesthetist, that my anesthetist is not good. So like what I have, because we have done all three technique, and out of this now I feel that as far as the irrigation is concerned, PSLD is a better technique. So now again, so this was the issue, like we have so many options for the endoscopy. So I'll just tell you about my protocol. So like, first of all, any patient with a disc problem, we just divide into two category. One is inflammation, one is a compression. So inflammation, we know that any anti-inflammatory rest medication, or even the steroid injection, epidural, intradiscal, it works very well. Now for the endoscopy, so for the endoscopy, for any kind of disc herniation, the transforaminal is still one of the best technique, because it has several very good advantage, because you are not going from the midline, you are away from the vascular structure, you are away from the neural structure. Procedure is very simple, and once you are expert, you can just finish the case in 20-30 minutes. So still for the discectomy, transforaminal is a endoscopy is the best option. Now for the stenosis, so particularly I follow this slide. So like if I have to do the bilateral decompression, then I just do the PSLD. So PSLD can be done at the cervical, thoracic, and lumbar level. Now in some of the patients, they have the lateral canal stenosis as well as the foraminal stenosis. So in those cases, I will do the unilateral decompression, and at the same time you can do the foraminotomy in an excellent way. And patient with only exiting root pathology. So mostly you see with the collapsed disc. So here we do the paraspinal decompression. So now the most important thing here is as we know about the pathology of the stenosis. So basic pathology of the stenosis lies in the lateral canal and in the foraminal area. So whatever you do with the central decompression, it's not going to help much with the patient. But doing the lateral decompression and doing the decompression up to the extent that you can see the lateral part of the root, that is the only adequate enough decompression. And depend upon the foraminal stenosis, you can work on the foramen. And with the interlaminar endoscopy, you can very well work on the superior articular process, tip of the superior articular process. You can even go inside and do the decompression. And the one more advantage about interlaminar endoscopy, that you have the 15-degree scopes. So because of this 15-degree, you will have the excellent image of the canal when you put the endoscope inside in the all four corners. So this is very important, that you can just decompress the all four corners. So now about the instruments. So like we have three different endoscope: 6.9, 8.4 and 10 millimeter. So like 6.9 endoscope is having the 4.3 working channel, and this all are 15-degree. So I use this 4.3 for the sometime for the small cervical foraminotomy, and for only for doing the disc cases for the interlaminar. 5.7 I use mainly for the bilateral decompression. So now this is also very important, that people are confused that which scope to buy, 8.4 or 10 millimeter. But 8.4 millimeter is the most optimal scope, and we have designed the instrument according to the working channel. So you see what happens, like 8.4 is very good for the bilateral decompression, and what we have done, that most of the instrument, see what happens, that in stenosis decompression, the bleeding is the main issue. So what is going to happen once you dock and once you start working, the bleeding is going to trouble you. Now if you increase the fluid pressure, you will have the issues related to the fluid. So we have designed the instrument that will exactly fit to the working channel. So what happens once you like you have the hazy picture because of the blood, but once you put the instrument inside, then you can see that there is a kind of a seal provided by the instrument, and exactly you can see that your picture becomes very clear. So the instruments and the scopes, they are matching, and you will only see that once you use the same set. So you will realize that the bleeding issue, what happens with the same scope and with the same diameter of the instrument, you are very comfortable. And this 10 millimeter scope, so we have planned this endoscope for doing the endoscopic fusion. Okay. So now this is a dilator and a cannula. So it's a standard thing. Then we have a small grasper, 3 and 4 millimeter. So these are the simple grasper. Now these are the most important instrument, the Carrison punches. So you see what happens, the shaft of this Carrisons, they are same, only the tip is different. So depend upon your comfort. So like I use 2 and 3 millimeter Carrison mainly for the lumbar area, and the 1 and 2 millimeter for the cervical area. And this is one of the very unique instrument we have designed. So this helps you to do the discectomy. So this is we call it the root retractor. So what happens, mostly in some of the standard interlaminar technique, the people just put the sleeve inside the canal, and they just do the discectomy. So they don't know what is outside the sleeve. So now see what with this instrument, what happens, you put the scope, everything is under vision, and then you put the root retractor. So you put on the lateral side and you just rotate on to the medial side. So what happens, that you are on the disc and you can see everything. And then we have the different annulotome and the knife and the grasper. So this all will go through this root retractor. So your discectomy is exactly under vision. So you exactly know that what you are doing. So sometime in the process of just putting the sleeve without seeing it outside, you can have some issue related to the nerve injury, and that can be missed. So now about the technique. So what we how we go about. So you see, depend upon the pathology. So suppose if I am doing the unilateral decompression, or if I am doing the discectomy, I will use the medial facet as a docking point. And if I am doing the bilateral decompression, then my docking point will be upper spinolaminar junction as medial as possible. So you will have the more advantage. You can go to the contralateral side. So in AP view, you have to dock on this point, and in the lateral view, you should be either the parallel to the inferior end plate or to the disc plane, depend upon your comfort. So this is exactly the docking point. Okay, I'll take this paraspinal little later. Okay, I think I'll just go. So now you see in the paraspinal decompression, we just go 1 centimeter lateral to the facet line, and we dock on the facet, and then we just try to do the bone drilling in the kind of arch. So you drill the facet, the supraarticular process, then you go to the isthmus, and then you go to the transverse process. So this 3 area you just do the decompression. So mostly we have seen this paraspinal decompression is required in post fusion patient, where you have the adjacent segment disease, and when you don't want, and you see the classically the exiting root pathology. So here also it's doing the selective nerve root block is very important, and if you do the selective nerve root block, you will be able to exactly know. So the selective nerve root block is different from the transforaminal injection. In selective nerve root block, your amount of the local anesthetic is very small, very small, as small as possible. So what you do, you go to the transforaminal area, you just inject the dye, maybe 0.1, 0.2 cc. If you just you are just able to see the nerve root, then you just put the local anesthesia as small as possible, maybe less than 0.5 ml. So it will just selectively block the nerve, and then you know that what is the difference in the patient's symptoms. If the patient are fine, so you can just proceed with the paraspinal decompression, and you exactly know that what is going to happen with your patient, because this is going to serve as a diagnostic procedure, and the paraspinal will serve as a therapeutic. And one most important finding which I have seen, that like in most of the patient, I was not aware that even this paraspinal decompression or the interlaminar decompression can give back pain relief also. So now, like we understand that even the back pain is more because of the pressure inside. So if you relieve the pressure, still the back pain also relieves in those patients. Otherwise, I used to always believe that the back pain is always because of the annular tear, and the annular tear is not healing. But especially when you have the stenosis, and when you see the patient is having the classical claudication symptoms, usually this decompression also works for the back pain also. So you see, this is one of my very close friend, and I learned this interlaminar endoscopy with him, and so drilling is very important, because you have to do a lot of bone work to just get the drilling, and the bone decompression is must. But you can beautifully do the exiting root decompression, very nice. You will find out the radicular artery. You have to cauterize the radicular artery, and then you can go ahead. So like if somebody is saying that I can do the stenosis decompression without the drill, I say it's not possible. Definitely not possible, because you need to do a lot of bony work for this. Now you see, this is something very different. What we are doing is we are doing all the decompression, including cervical also, under the local anesthesia. So now we have done almost over 500 cases for under local anesthesia. We are very comfortable. We have the protocol for and you see, this is going to make you something very different, because the moment you say that you are going to do the local anesthesia, you will be able to see all those patients who are not fit. And see, like in my practice in Ahmedabad, we have so many big spine surgeons. You can just finish your job and you can just do. So the good thing is, like, see, this patient was having the myasthenia gravis, so he was denied by surgery by almost everyone that no, you cannot get the anesthesia. But once you do this, you realize that local anesthesia, everything is possible. Only thing, sometime when you are working close to the nerve, and when you are working to the disc, or when you have to do the retraction, sorry. So when you have to do the nerve retraction, at that time the patient is having some pain. So like you always have the second port of the scope. You just take the local lignocaine, you put the lignocaine, wait for some time, and then you can just finish. And like, see, my trial for doing this under local anesthesia, because I work in Africa, and in Africa we have the huge patient, like 100 kilo is very minimal, sometime 120, 130, up to 150. So like our anesthetists, they are always having some, like, say, okay, Siraj, to do something, the GA is going to be difficult. So we did a lot of trial. That initially I used to do the transforaminal epidural, putting the local anesthesia. We used to do the sometime the spinal anesthesia. But gradually we realized that there's some, like, what exactly I do. I just put the spinal needle, go on to the upper lamina. So I just bend the needle. So we know that periosteum is only the pain sensitive part. I use the local anesthesia as a sensory dose. So local anesthetic works on the nerves depend upon the concentration. If it is a high concentration, it will give the motor block. If it is a lower concentration, it's only going to give the sensory block. So you just dock there. So you do the 3-point injection. You do on the upper lamina, on the facet, and the lower lamina, and then while coming out, you just infiltrate everything. So this will just anesthetize your complete tract, and then just you put the dilator and everything. So the things will be very, very smooth, and even the drilling and everything, the patient will be very comfortable, because in the drilling of the bone, the periosteum is the only pain sensitive area, and you can just go ahead with your all the job. Now the good thing is, we can expand our indication also. So like this patient, like she is very old, and she was just said no to screws. So she is my anesthetist. So I'm just asking her that what anesthesia you give. So she just telling that no anesthesia. So she always just observe the patient. So now you see, I just want to show you the MRI. So like this is also patient we did almost 1.5 years back. So I select this kind of patient when they have the unilateral radiculopathy. You can just definitely go ahead with your unilateral decompression, and they really do very well. So you can see here, the central canal is quite okay. The lateral side is, and the foramen is narrow, and once you do this, you can see that nicely. So now even see what we do, that in some of the patients, those who are having the degenerative listhesis with posterior canal stenosis, so we just do the posterior decompression, and since we are not removing the disc, we just do the annuloplasty, and then you can just put the 4 screws. So you can see that this is the patient will have the 5 cut, 4 for the MI screw, and the 1 is for the posterior decompression. So in that case, you don't have to go and work on the disc, because since you are not removing the disc, and you are just doing the annuloplasty, and you have make the room for the nerve free. So just putting the screw is also sufficient for those patients. So now I'll just show the actual operative step. So this is about the case which we did for the cervical C3-4 laminectomy and bilateral decompression. So this is the way how we do this. So you see, you have the excellent picture, excellent visualization, and you know the quality of the scopes matters a lot. So there are a lot of different company, but when you see that you have the excellent image and the excellent optics, your job is quite good. So once you identify the structure, and then you start the drilling of the lamina. So usually we start with the upper lamina. In cervical area, we just try to find out the V point, and just try to drill and make the hole. So you drill the lamina till you are able to put your instruments inside. So you have to do the bond work till you get the enough space for your instrument to be inside. So you can see. And this is also one of the very nice drill we have designed. So this is the diamond tip. The advantage of diamond tip is it just turns the bone into the powder. So you don't have a much issue with the bleeding control. But you can see that you can do all the job excellently. And here there is again a confusion about the size of the burr. But I tell you that we are using this 3.8 millimeter burr. And if you want to do so, here in the endoscopic drilling, we are doing the drilling with the side, not with the tip, because you want to do everything under vision. And this drilling, if you use the bigger size of the drill, you don't get the complete eye view. So then in that case, the things are not into directly under the vision. So it's absolutely important to do the drilling also under vision. So you definitely don't need the size of the drill, because the people are confused that why not the bigger size, it will do your job faster. But you don't have to do much of the bone work, and especially in cervical area, the lamina is very thin. You have to be more careful. If you just do the over drilling, you can just go inside. So then you can see this, we use the Carison and the other instrument. So once you are able to put the Carison inside, you will be just able to do the rest of the job, and you can see the phlegm inside. And then you see this is finally the dura is decompressed. So like you see, this is also one of the case where you can see this is the lumbar decompression. So this was unilateral pathology, and I did the discectomy. So you can see the discectomy defect, and this is the final picture. So you can see this is the exactly picture. You can see that we can see the lateral edge of the root. You can see the dura, and see once you do the bilateral decompression, you have this excellent picture. So if you have the very good scope, this should be the quality of your view. And you see, you enjoy doing the surgery if you have the good instruments and particularly the good scope. And then we always put the small drain. So the small drain is going to help you. So we just keep the drain for the overnight, and the next day, if it is less than 20 ml, we just remove the drain. So this is I said that is always recommended. I put the drain in almost all the patient, because this is not going to do any harm. And see what also I do that after keeping the drain, we just take the stitch and then we put the PRP, liquid PRP. So that is also one of the very powerful anti-inflammatory, and then we just close the drain for maybe around 10 minutes. So the liquid PRP just stays inside, and it also has a very powerful anti-inflammatory effect. So the drain is also, for me, it's useful for inject the PRP after you seal. If you put it before, the PRP is going to come out. So now this was I'm talking about doing the foraminoplasty from inside. So like you see, you can see the picture. So you can see that this is the foraminal area, and like this guy was having the foot drop, and he was an old guy, and he was having stenosis also. So I did the unilateral decompression as well as the foraminotomy. So you see, you can go lateral in the foramen till you find out the phlegm, and then you remove, you will see the epidural fat. So once you reach the epidural fat, and you exactly see on this the X-ray view that you are inside the foramen. So I can just show this the slide again. You can see the picture here. So this is the exactly area where we have reached. So I think we already covered about the paraspinal, so I'm not going to go into the detail. So this is the final picture where you see the exiting route, and you have done the enough decompression, and you see you have drilled the tip of the SAP, you have drilled the isthmus, you have drilled the lateral process also. So now you see we have little change up with our technique. So it's like most of the time when we have the chronic and organized or the black disc, we don't remove the disc. We just go with the posterior decompression, because the moment you remove the disc is going to collapse and it will have the subsidence. So it will have the consequences. But if you just do the foraminoplasty and you just do the posterior decompression, this is more than enough for most of your patient. And especially for the chronic disc, you don't need to remove those discs. So like you see, this is a recent case I did for a very young girl. She was having I think 4, 5 or 5, 6. So you see, this is my cannula, and here, like this video especially I wanted to show that the girl is awake. I was talking to the patient, and she said that I'm very comfortable. So this cervical cases also we regularly do it under local anesthesia, and we are very comfortable. So I'll not go into detail, but otherwise like this is the longest follow-up I have for my patient, more than 3 years, and he was having the very severe C3/4 myelopathy. So in this video I am talking to the patient directly. So this patient says me exactly that he has a relief in the pain immediately, but there was some numbness here, and exactly he used to fall while walking. So he said that it took me 6 months to get the relief from the fall, and at the end of 3 years he is now able to walk for more than 3 kilometers. Thank you. So any question we can. So we are going to perform one bilateral PSA. So I think the more of the point we can discuss while operating, but yeah, I can do it under local. Yeah, I'll yeah. I'll do it under local. In fact, I prefer to do it under local, because you see, we believe that your awake patient is your best neurological monitor, and see what is anything is going to happen to the patient. And especially I am not concerned about the neurological injury. I am especially concerned about the fluid pressure, and initially this is going to happen if you're going to take long time. I say that if you are more than 90 minutes, you definitely have to have the issues related to the fluid. There is no doubt. If your patient is sleeping, the patient doesn't report you, but this happens in all the patient, I tell you. So the anesthetist will manage with the medication, but you see, otherwise the blood pressure doesn't have much effect except the artery. You see, the blood pressure is an arterial phenomenon. So And you see, where the good thing is like the difference is when the patient is anesthetized, it's more of the abdominal pressure which is reflecting as a congestion to the epidural veins. So that is the reason you are going to encounter more bleeding. But once your patient is awake, so like I don't have much issue about the bleeding, because you can, and you see the bleeding is happening, you have the all the measures to take the control.
Yeah, but I think we are not knowing about this, so we have already anesthetized the patient, positioned him. So
Okay.
this will be done under GA. Thanks for the talk, Shiraj.
Okay.
Any questions?
No, not the removal of the drain. Once you put the drain, then once once everything is sealed, then we put the PRP through, and then we connect with the drain. So we use the mini wake drain, and it's always a positive drain. So what we do, we use the heparin. We take the blood, do the centrifuge inside the theater, and then take out with the syringe, and then just putting the needle inside the drain, and then just put it inside, and then keep it closed for around 10-15 minutes, so till they finish the cleaning the patient and everything. So then they put the drain once we are shifting. So the PRP, like I think Dr. Natkani sir will give the but you see, I tell you, one of the, like for me, one of the game changer in endoscopic surgery is a use of PRP, because it's a very powerful anti-inflammatory. It once you do the spinning of the blood, it gives you the growth factors, because the spinning will give the growth factor from the platelets. So even that is so good for your patient that even after, so like I started using for the transfemoral endoscopy. So we used to use the DAY-1 plug, the platelet plug. If you don't use this anticoagulant, so you will get a gel, and then at the end of surgery, so like you see, your all the patient is going to ask you, Dr. Saab, when you remove the disc, what you are going to replace. So this was one of the excellent answer. No, we are going to take your blood cell, and then we are going to put this, and you will get this much big the gel. So you just hold it with the forceps, and through the sleeve you just put inside. So then we had some issue related to the gel, the mechanical compression or something. So then we just started putting the heparin. So it will heparin will give you the liquid preparation. So then you put this liquid preparation inside. So that is something is going to help you. So it's one of the very powerful anti-inflammatory. Even we have done in all those patients, we don't give any painkiller after that, and still the patients are very fine. So so you see, for me it's going to serve the three purpose. One is it's a platelet. So the platelet is the initiator of the blood coagulation. So it's going to take care about all your small bleeding, oozing. Second thing is it's a anti-inflammatory. So it's going to work as a to reduce the inflammation. And the third thing is, maybe by chance if you have some concussion or to the nerve, or maybe the small dural injury or something, this is going to seal it. So for me, like since I said there is no disadvantage, there is nothing which we are doing, even there is no expense, there is nothing great we are doing, but just doing this small thing, it definitely helps you a lot.
Yeah, thank you for your talk, Shiraj. Any more questions? I request Dr. Harish
Okay, thank you.
to just hand over a moment to Shiraj. Just a minute. Dr. Harish is a senior orthopedic surgeon in Mysore, and I was ex-president of MOA as well as Indian Medical Association. Thank you. We move on to our next talk. That will be by Dr. Bhupesh again. This was a talk which was supposed to be completed yesterday. TFE in discogenic back pain. You want to do that tomorrow? Okay. Then continue with your talk. You ready after this or no? So Dr. Mahesh's talk will be on interlaminar endoscopy, concepts and philosophy and technique.
Good morning to all. I'll be talking about interlaminar endoscopy, the basic aspects, how I do it. So you have two approaches. Yesterday we talked about transforaminal approach. So today I'll be talking about the interlaminar approach. So you may be wondering why we should be doing interlaminar approach. Interlaminar approach has definitive advantages when compared to transforaminal approach. It is the least invasive approach for alpha S1. Yesterday we have seen alpha S1 discectomy done with the interlaminar approach. Just cut the phlegm, you are on the disc, and it is the least invasive and less radiation. So I can do interlaminar approach with 1 cm shot or 2 cm shots, whereas if you are doing a transforaminal work you require many radiation. So it is definitely advantageous, and it gives easy access to migrated disc. Yesterday you have seen L4 for upmigrated disc taking long time, whereas if you have done interlaminar approach you could have finished much quicker, and it gives excellent decompression of the root as well as the dura, which is not possible with transforaminal approach. And you can go to the contralateral side very easily with interlaminar approach. And you have excellent mobility of the scope as well as cannula, whereas when we do transforaminal approach the mobility is very limited, and it is similar to the traditional open spine surgery which has been there for many years. So it is quite familiar, and learning curve is definitely shorter, and you have applications in dorsal and cervical spine. Cervical endoscopy, interlaminar endoscopy is an excellent procedure, and it avoids fusion in many patients, and as I said, learning curve is shorter. So indication you can do in multiple indications like disc herniation, canal stenosis, foraminal stenosis, recurrent disc prolapse, caudate venous syndrome, degenerative listhesis. We do even fusion with endoscopy. Maybe tomorrow we may be showing one of the cases, discal cyst, discitis, abscess drainage tumors. So it has various indications. Contraindication, if the patient is unfit for anesthesia, then it is a contraindication. Surgeon not experienced in endoscopy cannot do interlaminar endoscopy, and if there is active infection in the body, then it is contraindicated. Anesthesia we do either under general, spinal or epidural, and as Shiraj said, he is doing under local anesthesia, which may be some painful, because I have my reservations about local anesthesia, because even with transforaminal endoscopy, which is the least invasive procedure, we still find some patients don't tolerate under local anesthesia. So interlaminar endoscopy is definitely more invasive than transforaminal surgery. So local anesthesia will be little difficult. I generally do 1-2 levels under spinal anesthesia, which is very comfortable, and patient being awake and aware, he will tell you if there is neck pain or headache, which warns you about fluid pressure. Positioning, we do it under prone position using this frame, because patient is awake and conscious. He has to be comfortable. The normal bolsters are not good, and abdomen has to be free. Coming to marking, in the AP it is just lateral to midline, very simple, just lateral to the spinous process, you go inside. And in the lateral view for alpha S1, if you are doing a disc, this is the approach, you dock at the lower end plate. For 4-5 you can do either at the lower end plate, that is interlaminar docking, or you can do a translaminar docking. Both approaches are possible, either interlaminar or translaminar. This is translaminar, you go and hit the lamina and dock there. Otherwise you have to go at the interlaminar window, which is little inferior. Both you can do, but if you are doing a fusion, it always has to be a translaminar docking, because to put the cage you need to be exactly parallel to the disc. So anesthesia we have already said. We require some hypotension for control of bleeding. So systolic BP should be around 100 or below. Otherwise there may be more bleeding from the bone. You need to have good cautery systems, monopolar, RF, and you need to have a good burst system, and you should have a very good camera and endoscope. Scopes, we can use either a 4.3 mm working channel scope or a PSLD scope, which comes in either 5.6 or 6 or 7 depending on which make you are using, and burst you should use whichever is available. We prepare parts, marking I already told, and incision is depending on your scope. You may have to put 8 mm or 10 mm, whatever, depending on your scope size. So interlaminar scope, we make an incision of about 8 millimeter. PSLD scope, little bigger incision. You can do either a vertical or transverse incision. I always prefer transverse incision because they heal much better, and I just close it with a single subcutaneous stitch, so that whatever bleeding is there, it will come out. I never use drain. So far I have never used drain in any patient, and I never had problems, because I never close the skin. Once you close the skin tightly, you need to put a drain. If you don't close the skin tightly, I just take a subcutaneous stitch, so there is enough gap for whatever bleeding happening there, it will come out. So you don't require drain. So everything comes with a cost. So this wound heals very well. In case if you have to open, you can still make a vertical midline incision, and this will not affect wound healing because it is very small incision. Of course, if you want to put a vertical incision, you can still put. Access, I have told, either translaminar or interlaminar. Always feel the lamina and always check the level, because this is very important, otherwise you may easily miss the level. So you should not be missing the level. So always check under C-arm and confirm, because what happens is even 1 centimeter mismatch can land you in wrong level, because it may be the direction or inclination, you may still miss the level. So always confirm the level under C-arm when there is doubt. So we have to take care of lordosis, because especially for 5 and 5S1 you may have to tilt the dilator and cannula and avoid wrong levels. So these are we insert dilator for alpha S1 level. You can see it is always below the disc, because the interlaminar window is always below the disc, but we can still manage with this approach for a discectomy. This is for 4-5. This is how we dock the cannula. So then we put the cannula, and bevel should be facing midline. That is where you start working. And if there is doubt, always check. So the first thing when we encounter when we put the scope is the soft tissue. So this part is initially difficult for the beginner. So we need to clear the soft tissue. You can use RF or whatever coagulation system you have. I use monopolar because it is very fast, very effective, and much less expensive for me, because one monopolar probe you can use for 100-200 cases without any issues, and it is quite safe to use monopolar over the bone, but you should never use it over the dura or the near the roots. So with monopolar you can clear the soft tissues, you can ablate the soft tissues. So basically you have to define the bony anatomy before you start drilling, and you have to control all the bleeders, because most of the bleeders will be muscular. So unless you control these muscular bleeders, they will keep irritating you till the end. So this is a monopolar probe I am using. Otherwise you can use RF also, it is not a problem. So whatever is available you can use. So you need to define the lamina, the facet joint, the lower lamina, the ligamentum flavum, and the lateral edge of the lamina. So this is, sorry. One second. So at the end you have to define the lamina here. This is the lamina. Then you come to the lateral side. This is the facet joint here. This is the facet here. You can see the facet there. And you expose the interlaminar window. And once you do that, you have to start drilling. So you can use some kind of drill, whatever you have. So I use these striker attachment drills, which fix with the striker shaver system. So basically you do the laminotomy. The procedure remains the same. You do the lamina, whether it is PSLD, whether it is interlaminar endoscopy or UBE. We need to cut some bone depending on which is the pathology. So you start at the lower edge of the lamina, or you can start at the descending facet and start drilling. It depends on how you are trained. So initially you can use cutting burrs, which is very fast. So cutting burrs, they cut very fast. But as you are nearing your completion of laminotomy, you have to change over to diamond burr, which helps in two ways. The diamond burrs, one, it controls the bleeding, and the second thing is it is much safer than a cutting burr when you are close to the dura. So how do you know you are not cutting too much bone? You have to see the lateral edge of the lamina. So now this is the diamond burr. So I am close to the bone here, I mean close to the dura here, and also it helps in controlling the bleeding. So if you are worried about, I never use any protection. So if you are worried about the dural injury, when you are close to the dura, what you can do is you can lower the speed. So you can work in 2000, 3000 RPM and continue drilling, so that you are very safe. The disadvantage of using a sleeve is it obstructs the vision. So you don't see a good vision once you use a sleeve. So I never use any sleeve in the burrs. So it's always open burrs. So either diamond or cutting burrs. We also have oval burrs, which is also very useful. So these burrs in low speed, even if they dip into the canal, it will not cause dural injury. But if you use a cutting burr in high speed and dig into the canal, it may definitely cause dural tear. So this is the oval burr which is in place. This is a 4 mm oval burr which I am using. As Shiraj said, the bigger burr does not give too much of advantage. Actually, in fact, it is a disadvantage than a smaller burr. So smaller burrs are much better. There is no point in having a 6 mm or 7 mm burr. A 4 mm, 5 mm burr will do the job. So this is the completion. So once you complete, you see this laminotomy. Once the laminotomy is done, you have to do this flavum dissection. So what I do is I detach the flavum from the cranial end, from the caudal end, and medially and laterally. So if you detach the flavum from 4 corners, 4 margins, then you can pick it up as one piece and take it out. So this is the midline. So midline I am cutting. You can use a cutter. Go between the dura and the flavum and keep cutting. So when you cut, you lift it up and cut, so that you're not going to catch dura. So you can see the epidural fat which is coming in the field. So I am catching, lifting and cutting. So once you cut the phlegm fully, it starts floating there. Once the phlegm is floating, then you can pick it up and take it as one piece. If required, you can use a curette or dissector and dissect the phlegm from the dura. And once the phlegm is free, you pick it up and take it out. Sometimes you will have some strands which are still there, which you can use a kerrison and take it out. Once you take out the phlegm, there will be some epidural bleeding, which you can easily control with the radio frequency. So if there is a disc work, you can take out the disc by retracting the root. This patient had a huge disc, so which was removed. Then the other part is, if there is stenosis, you have to do over the top decompression. So to do over the top decompression, you have to, the basic thing is you have to drill the base of the spinous process. What we see is the base of the spinous process here, which has to be drilled. So I am using again the drill. You see the angle, so you tilt it towards you so that you are exposing the base of the spinous process, and there is enough space between the dura and this bone so that it is quite safe to drill, and you drill it always away from the dura, not towards the dura. So once we drill enough bone there, you get access to the phlegm. If you do not drill enough bone, then it becomes, the access becomes difficult, and that will end up with the more complications like dural tear. So if you make enough room with bony work, then contralateral decompression is very easy and we can finish in 5 minutes. And there will be some bleeders, vessels between the dura and the phlegm, and sometimes even the phlegm will have some vessels which need to be coagulated. So once it is coagulated, you can use either cutters or kerrisons to decompress the opposite side. So here I am using a cutter, or you can use a kerrison. So both will do the job. The cutter has to be an angulated cutter. A straight cutter will not do the job. It will go straight and catch the dura. So always use a angled annular cutter when you are doing a contralateral decompression. Angled annular cutter, it will go away from the dura and catch only the phlegm. You can use a kerrison also. If you are using a smaller scope, you need a smaller scope. Sometimes you may have to use a curette to peel the phlegm, which is also good. And in the end, you see this contralateral root which is free now. You can see the contralateral root here, which is decompressed. And that is the final decompression. This is the ipsilateral root after discectomy and decompression. The dural sac fully decompressed. You see this margin of bone. There is enough bone here, so we are not damaged the stability. So endpoint, you have to match the disc with the MRI if you are doing a discectomy. Full decompression of the dura and the root. Once you finish discectomy, you do annuloplasty, confirm the level when there is doubt, and close with the subcutaneous vehicle. Drain is left to you, so it depends on what is your preferred method. So I don't use drain. I'll just show 1 or 2 cases. This is a 44-year-old patient with chronic sciatica since 2 years with acute exacerbation. He was unable to sleep or lie down for 1 week, and pain was not controlled even with whatever analgesic. So we could not even do MRI because he was not able to sleep. So finally we had to give him epidural anesthesia and send him for MRI. So we got the MRI done. This was a picture. You can see down migrated L45 disc with the, if you see here, this is a chronic calcific hump because it is a chronic disc herniation with the acute fragment here. If you do a CT, this will be calcified, but you can make out on MRI itself it's a calcified disc, and this is acute fragment with facetal hypertrophy and canal stenosis. So this was done with the interlaminar decompression. So this is after bone work. You see the dura here. So this is the cranial end, this is the caudal end, this is the root here, this is the dura here. So once you expose enough space lateral to the dura, then you retract the dura. So I use a dura dissector now to retract the dura and expose the disc. You see this, the disc is here, and then we rotate the cannula. So you don't require any assistance for interlaminar endoscopy. The cannula is your assistant. So this is the root here. You retract the cannula to expose the disc. So this step you have to do it carefully because you don't want the root to be caught in between. So this is the disc herniation, and there will be blood vessels over the disc which you coagulate with radio frequency. And this is the root here. It is tense. There is a huge disc herniation which is causing him symptoms, which is already, partly it has ruptured here. Now the dura and the root is protected, it is away. Then you go for the disc and take it out. So that's a huge fragment which came out finally. You can see the size here. It's a massive fragment. And you see the calcific mass on the MRI. You see here. Can you see the calcified piece? So this was removed with using the cannula as a dissector. It is even yesterday I have shown you in the case. You can use the cannula as a dissector and take it out. You see, I dissect with the cannula edge. You separate it from the attachments and get up and take it out. This is calcific mass. You see. So whatever you see on MRI, you have to see intra-op. And if you're doing a post-op MRI, you should be able to define that. So this is the end plate osteophyte which I am removing the burr. With interlaminar approach, it is very easy to do osteophyte, calcified discs. Very easy to do laminar approach, whereas it is difficult with the transforaminal approach. Here the approach is very direct. You can directly drill whatever osteophyte is there. So I am using a diamond burr to drill osteophyte. Sorry. And some remaining disc is removed. This is a hard annulus which is cut and removed. and finally we do annuloplasty. This is the root which is decompressed now. You can see the inflamed root because of compression. Now it is all the humps and the osteophytes are removed. It is free. You can see the dural sac fully decompressed. The root is free. There is decompression, and patient was discharged in a day, and he is relieved with no complications. Another patient who is a pediatric surgeon who came with acute sciatica, S1 radiculopathy due to L5 disc exclusion. You see this massive disc fragment, down migrated disc here. So done with interlaminar endoscopy. This after opening the phlegm. You see the epidural here. So use RF to coagulate the epidural fat. The disc is already in front of you. The bigger the disc, the better, because it's already in front of you. So you expose the disc and take it out. There were multiple fragments. You can see that we have not retracted the root. We are just doing fragmentectomy here initially. Once sufficient amount of disc is removed, then you retract the root. So once you have removed sufficient disc, you retract the root and go for the down migrated fragment here. That is the down migrated fragment which you see on MRI. There is another small fragment lying under the root here. So everything is done under vision. This is the disc space. This is the S1 root which is fully decompressed now. And that is the final result. So that is the post-operative MRI. You can see all the fragments are removed. The down magnetic fragment is removed, and he is fine. This is the last case. This patient came with bilateral symptoms due to alpha S1 disc herniation. You can see on the foraminal extraforaminal fragment with the right-sided disc herniation. You see this, and that is the extraforaminal fragment. So what is the option? You have to do either transforaminal from one side and into other side. Here we did everything from interlaminar. We first did the discectomy from the right side. Contralateral side. This is the opposite side. You see here the disc is exposed. This is the foraminal extraforaminal fragment here. I have the bone here. The facet is here. This is the ascending facet here. The descending facet here. This is the facet joint. So this is the disc which is exposed and which was removed. Sorry. So that is how you can reach the extent. You can go to the contralateral foramen and all these fragments are out. Complications of interlaminar endoscopy: headache and neck pain because of fluid pressure. So there are ways to tackle it. Dural tear can happen, root injury and deficit, postoperative numbness, hematoma, discitis recurrence, facet damage, epidural fibrosis and arachnoiditis. These are the regular complications of any interlaminar surgery, but they are much less with the endoscopic procedure if you are careful. Take home message: it's a very versatile approach. It is least invasive for L5S1. Beware of complications and avoid them. And I say both approaches are complementary, and it gives great benefit for surgeon as well as patient to know both approaches. Thank you. Any time for questions, or we?
Any questions? The live surgery, they are ready. So, yeah.
So how do you manage the dural leak if you encounter? Yeah.
Dural leak, I may have 3 or 4 dural tears so far. One was 2-3 cases were because of highs going inside initially. But these tears are very small. When the small tear is very small, you just ignore it. You don't have to do anything. Just finish your work and come out. Because we have not made a big opening inside, this will not give you trouble. So you manage the tear conservatively. And I never had a huge tear where the roots had come out and had to do open repair. I never had this. Small tears, nothing will happen. Just ignore them. You don't have to do anything. But if there is a moderate tear, you can put a Duragen or some patch you can put inside and come out. If it is a big tear, you may have to open. But I never opened even one case for a dural tear.
Can you put Duragen with the saline? Will it stay there, or how to put the Duragen?
You take a Gaspar and at the end you put, and then take out everything.
At the end?
Yeah.
Okay.
Not initially. Once you finish everything, when you come out, you put it and come out. No, it doesn't.
So that had kind of transfer. But see, when
The with saline, without dural tear. So because I do them under spinal anesthesia, patient will tell whether there is neck pain or headache. If there is neck pain, headache, there are few options. One is you can give some sedation and continue to work. And what I do is I never put this plastic cap on the scope. You have a cap which acts like a seal, no? I never do that. It is always open. Even the channel for the outflow, it is always open. I never close any of the outflow channels. So that's why the incidence of pressure issues is less. And also we use only gravity irrigation, no pressure. So if there is problem, patient will always go on. So if there is too much of headache and neck pain, stop your procedure for 5-10 minutes. That will give you another 15-20 minutes for you to finish the work. But if you are doing under GA, you will never know what is happening with the patient. You will never know.
Do you give epidural or only spinal?
I can do under spinal or epidural, but generally I do under spinal. Because very simple, just one shot you finish everything.
So, the pressure issues with respect to headache, it's purely because of the pressure, or with respect to the water, or due to the position?
It is not because of position, it's purely because of water.
So any reverse Trendelenburg or Trendelenburg position, like it will help?
It may not help, because even if you put the patient head up, still the pressure is coming from the top.
Okay.
Little bit position up, changing up, it is not going to matter.
And when the pressure is less, and if the duration of surgery is, what does it affect?
It depends on duration of surgery. See, the headache and neck pain will start only after you open the flavum. Till you open the flavum, patient will not have. That's why before you open the flavum, you should finish all the bony work. Even the drilling of the base of the spinous thrust, everything you should finish. So, because once you open the flavum, you have limited time. Once the water enters the epidural space, the pressure starts building up. So, that's why you should finish everything before you open the flavum and open the epidural space. Once the epidural space is opened, the water will start going in, and it is highly variable. There are some patients who don't have any issues. Even if you operate for 2-3 hours, they have no issues. But some patient, within 5 minutes after opening the flavum, they start complaining of headache. So there is no fixed rule that you have
Duration.
30 minutes time, you have 1 hour time. There is nothing like that. It can happen in 5-10 minutes, or 2 hours. Patient may not be complaining of anything. I have done 5 levels decompression. That patient never had any headache, neck pain. 4 levels. But some patients, 1 level itself, after 5-10 minutes, they complain of headache. So we have not changed the pressure or any parameters.
Okay. Yeah, Dr. Sriharsh has a question for you.
Thank you very much for a very nice presentation. Mine is a more basic question. FIS1 transforaminal, of course, there are some access related issues,
Yes.
although purists like Dr. Gore never believed that transiliac is necessary.
Yeah.
But you started transiliac and you made it look very easy.
Yes.
And probably 2 or 3 years back, you would say you can do all the surgeries FIS1 through transiliac.
Yes, we can.
Now that you have started doing interlaminar, what is your practice like? You do most of the cases transforaminal and occasional interlaminar, or most of the cases interlaminar and occasional transforaminal?
Today it has
I mean,
become.
how do you decide? I mean, there are a lot of newbies here who are confused
Yeah,
when
yeah.
to use which one, which is an absolute indication for transforaminal.
Yeah. Actually, we have a talk on this topic. About my practice, today I do most of them interlaminar and few transforaminal. So that is because of some practical issues. It's not that transforaminal approach is bad or anything. Transforaminal approach is a very good approach for disc herniation, but transforaminal approach has limitations, because you cannot do a good stenosis work with the transforaminal approach. And the interlaminar approach, I do most interlaminar approach, because if you have a cervical disc, interlaminar approach is the best procedure. Nothing like interlaminar cervical endoscopy. They do extremely well. It is a very simple, straightforward procedure. 30 minutes you can finish a decompression or discectomy, whatever. Gives excellent results. And radiation, because I can do interlaminar approach with one CM shot or 2 CM shots, whereas transforaminal I have to take multiple CM shots. And if you see the instruments, we require very few instruments for interlaminar approach. Very few. One cutter, good annular cutter, Kerrison, and few graspers. That's all. We don't require anything special like flexible cutter, flexible graspers, all these things. Yesterday you have seen 2 cases, interlaminar L5S1, transforaminal L5S1, where I had to spend more time for transforaminal approach, whereas interlaminar approach we finished in 30 minutes. So that's why we have shifted more to interlaminar approach. Even the foraminal, extraforaminal herniation we can still do with the interlaminar approach. And especially by doing this interlaminar, many of these degenerative listhesis cases which are relatively stable, we can just address with interlaminar endoscopy. No fusion required, which is excellent for the patient. You avoid screws and the complications associated with screws. So it has given us much more freedom, and we are able to offer endoscopy in much more patients than just doing only transforaminal approach.
Exactly what I wanted to hear from you, that there are some speakers saying that this is the only way, this is the best way, but there are many ways to do things, and that's what you summarized.
Yeah,
Thank you so much.
we have seen both ends. It's not that we have seen only one end of talking.
How your interlaminar approach is differ from Destandos technique, where they're also the same interlaminar approach?
See, the basic endpoint of all these approaches are the same. It is not different. But how we do it, because as you know, the lesser invasive is better. I hope you agree with this. And this is the least invasive than Destando. And less invasive is always better for obvious reasons. We don't have to talk about it. Actually, Dr. Lim does even 3-4 levels with one incision, but I don't prefer that because he will have to put 4 drains in through because everything comes with a cost. For me, it is only one skin incision, which doesn't matter. I'm not making a big cut, one small incision, and I prefer to do it separate incision for separate levels. Even 4-5 5S1, I always take separate incisions because I never use drain.
Yeah, I guess
UB, you have to create a big dead space inside, otherwise you cannot work.
no, I think 3 things here. One is, of course, the type of the disc prolapse and the personal choice of the surgeon. And of course, as he said, the practical situation. So definitely there's a little bit of more radiation exposure in transfemoral compared to interlaminar, I think. But then being orthopedic surgeons, we are exposed. So comfort-wise, yeah, again, it's a personal choice. That's what I feel, because I do only transfemoral. So all my surgeries are transfemoral. Of course, we have some difficulty with L5S1 when it is highly accessed. But then we usually try to get away. Like recently we had a case with an Sangisar, but then it is fine. But as I said, when you grow as a surgeon and when you're wanted by many people, then you cannot spend hours together operating 1 case or 2 cases. So that is a situation where you start slowly thinking of any other procedure which can finish off your work quickly and something. There are some gray areas in between. That is, again, it's a choice dependent. With experience, you evolve and try to save your time, save your health, to look after your health, plus your the expenses involved in performing a surgery. So it's a mix of everything. I think there is no straightforward question to say that, okay, you do this, you do that. But as Dr. Sukumar also mentioned yesterday, some cases where there is a calcified disc with osteophytes and he prefers interlaminar than transforaminal. So that can be a situation where the case, the surgery, it demands transfemoral or interlaminar. But otherwise, I think it's more of a choice and your expertise, your comfort with the procedure. That's what I feel.
Yes.
I think finally the thing to decide is what is the route that is least invasive. Least invasive in terms of damage to the posterior midline muscles and structure. So in that respect, the transforaminal route is a natural approach to the spine. If at all you can tackle a pathology through the transforaminal approach, then obviously it is much better in the longer term than using a midline or paramidline approach. If you cannot tackle a pathology from the transforaminal approach, then obviously the most overwhelming thing is to tackle the pathology. So you tackle the pathology with whatever skill and instruments you have. But let us not forget that the transforaminal access per se, is the least damaging to the mobile segment of the spine. We are not touching the rotators, we are not touching the capsule, we are not touching any of the important, because all this surgery looks great when the patient is lying down. Okay, we don't have dynamic x-rays, we don't have dynamic assessment of symptoms. So as I see the future, it might be a matter of convenience that we are doing pathologies from the midline or paramidline approach. But in the future, if I was to put my money on something, I would say transforaminal route to the pathology is the least invasive.
Yeah, it is least invasive for L4, I mean for all levels except 5S1. But suppose if I have an extruded disc at L4-5, if I do interlaminar approach, I just do fragmentectomy. I don't damage the disc. If you are going to transforaminal approach, you have to enter the disc and then reach the pathology. So this also you have to consider. Whereas I am not going to, if I have a manual laborer who has come with the extruded disc, I just do only fragment, I don't damage the remaining of the disc. So this also you should consider, which is possible only with the interlaminar approach. You have to debulk the disc a little bit. You have to go more lateral, or you may have to go from the axilla. So there are ways depending on what pathology you are dealing with. There is no special instrument. You debulk and reduce the hump and then start taking it. Yes, I use the same scope. Transforaminal, interlaminar, cervical, I do with one scope.
Sir, Dr. Gore wants to make a comment here. Sir, are you online? Yeah.
Yeah, I'm online. Can I make a comment?
Yeah, please go ahead, sir.
You see, all this talk of interlaminar surgery and the new ways of doing interlaminar, etc., is fine. But we forget one thing. When the problem is with the disc, which is anterior to the dural sac, we have no business to break the posterior wall, the interlaminar structures, and partly destabilize the spine. There's no business at all. We should not touch the posterior midline. No argument can support any logic related to interlaminar access because the pathology is anterior to the dura. The second problem is when you want to reach that pathology, you must go around the dura, and the dura is covered by the lamina. There is no business for you to touch the lamina and remove the lamina. Whatever arguments, logic, reasoning, etc. you give is all irrelevant as far as the pathology which is anterior is concerned. The second point is in all these talks which I heard yesterday and today, one thing has not been highlighted, and that is interlaminar window is not in the same plane as the disc. It is below that plane. Second point, as Dr. Mahesh said, the interlaminar window at 5-1 is quite big. So maybe there could be a point in going there because you don't really have to drill any bone or remove any lamina because the window itself is very big. If you consider surgery from D12 L1 right up to L5 S1, transforaminal approach is the only approach which takes you to the pathology without touching anything. You don't touch anything. You don't remove anything. All these arguments about multi-level, one more point, multi-level is an image finding. There are hardly patients who have a multi-level pathology, and you can always do a DTI, that is diffusion tensor imaging, and find out which root is affected rather than how many discs are showing changes. And the final point is, all these years, right from 1934, we have been doing interlaminar, translaminar, inferior articular process removal surgeries. But we have forgotten that we are treating pain and we are not altering the natural history of the disease. So all these arguments of super refined interlaminar access like Destandu and irrigated Destandu and double tube Destandu and UBE and PSLD are just twisting of words as per my understanding of 24 years of transforaminal endoscopy. Our rationalization of what we do is an accepted phenomenon, so you can always support whatever you do. But science is science, logic is different. That's my comment. Thank you.
Thank you, sir. I think we stop here. Anybody who wants, as I said, again, it's a matter of your experience and matter of your choice. If you look at my journey, then I've been an open spine surgeon. And then when I came in touch with sir, then I started doing transforaminal endoscopy. Okay, back then there was no interlaminar, no talk of UBE or PSLD in India. Of course, they were doing it in Korea. But then, so I was exposed to one form of endoscopy and I liked the concept, the philosophy, so I have been part of that. And even though I came to know about other things, other aspects of other forms of endoscopy, I have stuck with transforaminal because my work in Mysore demands transforaminal more. So maybe your practice, maybe you could see more of a degenerative spine or things like what Janmajay had shown the videos yesterday. So you might see, okay, results through one form of endoscopy are a little different, so let me try the other one. That's your choice. So, but then, as sir said, as I believe, so transferable has been good for me, so I am going ahead with that. It doesn't mean that I be fanatical and say, okay, do only this, don't do anything else. It's I mean, you're free to think the way, your choice, the way you think. Yeah, exactly. So, you want to do this, you're free to choice. But then, it's a very difficult thing to support one thing entirely and say don't do the other one. You have your liberty to think and which you feel comfortable with. That choice is yours. Yeah. As a training program, that's why we included all other forms of endoscopy. Otherwise, the name, as somebody suggested to me that when you are naming it as transforaminal endoscopy, why you are including other forms of endoscopy? But then, for us, it may not matter. First thing. Second thing, because I don't want to be totally fanatical in saying that if I put the name also Tssula, so we do only transforaminal. So we thought, okay, we give exposure to regarding all forms of endoscopy. Let the delegates decide. Yeah. So we'll go live. They are waiting for us.
चलो इनको बोलो चालू करते हैं. Hello, Ravindra.
Yeah, I can see you are waiting since long time with that portal of yours. We can start. Please start. Sorry, very sorry for keeping you waiting.
Okay, Ravindra.
Yeah.
So we are ready.
Yes.
We can start with the MRI.
Yeah, please. Dr.
Okay.
Mahesha will coordinate because I don't have any knowledge of PSLD.
Yeah. Okay.
Okay, you show us the MRI.
So actually, I have not seen the patient. So basically, this patient had microdiscectomy for the left. You can see the MRI?
Not yet.
Mahisha, can you see the MRI?
Not yet.
Okay. Okay, now?
Not yet, not yet.
Okay, okay.
We are seeing endoscopic picture only.
They are arranging. Okay, ready?
This is one level or two level?
One level.
Okay.
So now I have not seen the patient. The history is told to me by Ankit. So this patient is having the microdiscectomy 4 years back on the left side.
Okay.
So you can see on the left side.
Okay.
And currently he is having the right side pain, and the pain is only for last 15 days. So our plan is to work on this, and there is the disc herniation also into the right canal also. So we are going to work on this right side, and we will take care about the disc also. But you can see this is a big phlegm also here.
He has pain on right side. Pain on the right side or left side?
Pain only on the right side.
But there is a big disc on the left side.
He has a surgery left side microdiscectomy 4 years back.
Okay.
So this right side pain is only for 15 days. Ankit, is there anything extra you want to tell? Say it again.
Right side pain. There is only right side pain since 15 days, and he had no symptoms on left side.
Okay, but MRI is showing a disc.
Yeah.
On the left side.
There's a soft.
Yeah. And this is this is.
Herniation is over here.
Okay, there is. Okay. Okay.
Yeah.
Can you show the other cuts, actual cuts, because we are seeing somewhere else.
So you see, this is from the right to left. So you can see the herniation here. Give me a minute. This one.
No, we can't see. Okay.
This one.
Okay. Yeah.
You can see that this is the herniation.
Okay.
So so this is a disc as well as stenosis. So we are going to take care about both.
Can you show the axial cut ones?
So this one is alpha S1.
Okay.
So you can see the left side is already been operated. The herniation is also on the left side, but this is a chronic and stabilized. So now this part, this is the disc, and you can see the big phlegm here also. So we're just going to go here, and we'll see. So let's do this right side decompression with discectomy.
Okay, you will go over the top and see the other side.
एक मिनट यहाँ पे दिखा दो. So we already have done the docking.
Yeah.
So this is the current picture, and this is the lateral view.
Okay.
Okay. So here you see in all the time of doing the endoscopy, you have to make sure that your sleeve is on the bone, and you always have to have the feeling.
Okay.
Because if you sleep, because especially for the alpha S1, there is a big window. You can sleep in. You can sleep the inside.
So you are docked on the lamina or the facet?
So we already have done the docking, and you can see that this is the upper spinal laminar junction, and as middle as possible.
Okay.
And in the lateral side, you are parallel with the disc space.
Okay. This patient is under GA or epidural?
Yeah,
or
patient already anesthetized. Yes.
GA.
Yeah.
Okay. This is a 7.1 channel scope or 5.6?
No, this is 5.7.
Okay.
So this is 5.7 working channel with 125 millimeter length, and the 8.4 is outer diameter. Okay. So now I'm just putting the endoscope inside. Now you have to hold the endoscope in a particular way, so you should always have a control of the endoscope, and at the same time you should have always the feeling. So I always held the endoscope with my own hand, and my thumb will.
So this is very important to control the scope and the cannula with one hand, because
no, just give me the last picture.
It looks simple, but when you practically do it, it's difficult. It is not easy till you get experienced.
Yeah, literally you have to do some exercise for your hand.
This is not like transformal surgery where your scope and cannula are fixed. Here it is not fixed, it is mobile. So you need to control, because you need to move the scope up and down depending on your pathology and what you're working with.
No, push towards me. So I'm just taking the last picture because it was, So this is okay for me. So you see, you have to now make the orientation that this is your final position of cannula. So you should always keep this angle in your mind. Okay. Now you can take the CM out. The other good thing about the interlaminar endoscopy is your radiation exposure is quite less. So what exactly now we are doing is we are just removing the small blood clot. So you see what you need to first do is with the grasper, you just make a feel that you are on the bone. So that is something your extra precaution. You always have to do this. So you know that your bone, because your bone is your friend, and bone is going to keep you safe. Now we'll just use the cautery.
Raj, from which side you are operating, from left or right?
We are on the right side.
And you are standing on right side as well?
Yeah. So here we will, like same like transforaminal, we just go on the same side. But if the time permits, we'll do just show you the contralateral decompression also. So you take a little time here just to make sure that you control all the bleeders, because you see that is the thing which is going to give you the very clear picture. Otherwise you will always have one or other kind of issue because of the bleeding. So everything should be in control. थोड़ा fast करो ना, थोड़ा high करो.
Dr. Siraj,
Yes.
endoscopically, please correlate the orientation.
Okay. Now you see we are on the right side of the patient. So we have dock on the right upper spinolaminar area. So this is the medial side. Okay. This is the medial side toward the spinous process. This is the upper lamina. This is toward the facet. So 6 o'clock is a facet, 3 is a lamina, upper lamina, and this will be here the lower lamina. You have to change the little trajectory of the scope. But here I can see that I am on the bone, I can feel it. Okay. So now my target is to identify the junction, and from that junction of the bone and the ligamentum flavum, and then we can start drilling. So we just first have to clean all the tissue which is coming in between. So make sure that you coagulate the tissue and then you just remove with the forceps, so your bone will be easily visible. Hello? चल देते फटाफट. કેમાં લાગશે કેમાં લાગશે ના ના ચાલશે. ચલો. So now I'm just cleaning the tissue. So again, every time I will check it that I am on the bone. Okay, so this is, you can see this with the forceps, and with any of the instrument, you just take it and make it sure you are on the bone. So we have 5 millimeter probe here also, but this cautery is not compatible. Otherwise, this initial with this 5 millimeter probe, you can just do all your bleeding control and exposure very fast. So you can use the normal cautery also here. So normally I keep the bipolar setting around 60 for when we are working outside the spine. And if you are, once you open up, you can go up to 20 or 10. Simple bipolar cautery is also okay. But if you have the high frequency or plasma, it's an added advantage. So you can focus on my hand. So you see what I am doing, that when I want to go close, I just release my thumb, so I'm going to go close. If I want to come out to have the larger picture, I just use my thumb to elevate the scope. So with the one hand, you are having the complete control, and you see you have the option to go in all the direction, this way, that way. So you can direct your vision where you want to work. थोड़ा क्वार्टरी बढ़ाओ ना, ये पावर बढ़ाओ. क्लीन कर. Yeah, now it's okay. So you see, this is a post-operative patient. Patient was operated from the same area in the midline, and we are very close to that area. So you may feel there will be more bleeders. Chalo, grasp पर. So again, before taking out, I will just check again. I am on the bone. So you see how you can make sure that you push and press with your bipolar probe, and then you can just coagulate. So you exactly know that you are on the right area. So you always have to make your vision very clear, so the things will be very comfortable for you. Give me grasper. So you can see here is the bone, and this is the junction. You can see this is the sleeping. So I will start my drilling over here. I am not very happy with the quality of the camera. Otherwise, if you have the good stores or striker camera, the picture थोड़ा देखो ना picture, because you see you can have very clear RF दादा. See, otherwise you should be with the camera. You should be able to clearly differentiate between the bone and the ligament. So चलो drill दे दो. यहाँ से फोकस यहाँ से होगा थोड़ा, ठीक है. फोकस यहाँ से. ये वाला. Let me just do the focus. I think this is little better. Sure, no problem. Okay, so now I'll just start the drilling. So again, before the start of drilling, you make sure you are on the bone. So we just confirm. So the drilling speed is around 25,000 RPM. So like you see, there is a special way I am holding the drill. You focus on my hand. So with the thumb and the index finger, I am holding the drill. This my middle finger is going to control the drill. So you will not just fall inside, and you can have the good control. So now this is all on your tactile feeling, that exactly where you are drilling. Okay, so this is very important.
Check.
So once we start drilling, you will be able to appreciate more.
Shiraj?
Good morning to all. To the doctors who work tirelessly day and night, putting their patients' well-being above their own, we extend our sincerest appreciation. Your unwavering dedication and sacrifice do not go unnoticed. Happy Doctors' Day. I would like to call Sri T.S. Srivatsa sir, MLA, KR Constituency on stage, please. And Dr. Sunil Nadkani, Dr. Ravindranath, Dr. Mahesha K. Dr. Sunil Nadkani sir and Dr. Mahesha K. Will be followed by lighting of lamp. Atish. Candle and match. Atish. Candle match. Sorry, yeah. Okay. Now I would request MLA Sir Srivatsa sir and Sunil Nadkani sir, Ravindranath and Dr. Mahesha sir to light the lamp. Thank you for your gracious presence, sir. Mr. Mahesh. Thank you, sir. I would like to request Dr. Ravindranath to have a keynote address.
Uh, it's a very auspicious day because today is Doctor's Day, and we are blessed with Srivatsa sir, who is MLA of KR constituency, and he has taken his time out in gracing this occasion. I thank him to be here for honoring us, and we take this opportunity to launch two systems which have been the hard work of many people, Gore sir and a company called S3V. The first system is Smriti system, which you saw yesterday. Gore sir talked about it regarding this new concept of lumbar canal stenosis, and the new system which the instruments were designed by him, of course manufactured by some other company in Maharashtra. And this system we are launching today. I believe Gore sir is also there online, Zoom online. Yeah. So I request Srivatsa sir to inaugurate that. ಇಲ್ಲೇ ಮಾಡಿ ಮೇಲಿದ್ದು ಮಾತ್ರ ಕೊಡಿ ಫಸ್ಟ್. request one. Now I request Srivastava sir to speak a few words.
So I will wish first Mr. Dr. Ravindranath and Satish Chandra Gore for unique conference held in Mysore. So I will congratulate Mr. Ravindranath first of all, and I will wish Doctor's Day. So I am comfortable in Kannada only. ಸೊ ಇವತ್ತು ಮೈಸೂರಲ್ಲಿ ಒಂದು ಒಳ್ಳೆಯ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ತಾವೆಲ್ಲರೂ ದೇಶದಿಂದ ಎಲ್ಲ ಕಡೆಯಿಂದ ಬಂದಿದ್ದೀರಿ. ಡಾಕ್ಟರ್ಸ್ಗೆ ನಾನು ತುಂಬ ಹೇಳೋದೆಲ್ಲ ಏನಿಲ್ಲ. ಈ ಒಂದು ಸರ್ಜರಿ ಲೈವ್ ನೋಡಿಕೊಂಡು ಮಾಡ್ತಾ ಇರುವಂಥದ್ದು, ಅದರಲ್ಲೂ ಸ್ಪೈನಿಗೆ ಸಂಬಂಧಪಟ್ಟಂಗೆ ಮಾಡ್ತಾ ಇರುವಂಥದ್ದು ಒಂದು ಯುನೀಕ್ ಆಪ್ರೇಷನ್ ಅನ್ನೋದನ್ನು ಕೇಳಿ ತಿಳ್ಕೊಂಡಿದ್ದೀನಿ. ಇವತ್ತು ಮೈಸೂರಲ್ಲಿ 2 ದಿವಸ, ನೆನ್ನೆ ಇವತ್ತು ಮತ್ತು ನಾಳೆ ನಡೆಯುತ್ತೆ ಅಂತ ಗೊತ್ತಾಗಿದೆ. ಸೊ ಇವತ್ತು ನನ್ನನ್ನು ಕರೆದು ನನ್ನ ಕೈಯಿಂದ ಇದರ ಉದ್ಘಾಟನೆಯನ್ನು ಮಾಡಿಸಿ ತಮ್ಮನ್ನೆಲ್ಲರನ್ನೂ ನೋಡುವ ರೀತಿಯಲ್ಲಿ ಡಾಕ್ಟರ್ ರವೀಂದ್ರನಾಥ್ ಇವರೆಲ್ಲ ಮಾಡಿದ್ದಾರೆ. ಸೊ ಮೈಸೂರಲ್ಲಿ ಇದೊಂದು ಗ್ರೇಟ್ ಆಪರ್ಚುನಿಟಿ ಅಂತ ಹೇಳಿದ್ರು ತಪ್ಪಾಗ್ಲಾರ್ದು. ನೀವೆಲ್ಲ ಮೈಸೂರಿಗೆ ಬಂದಿದ್ದೀರಾ ಆ್ಯಂಡ್ ಮೈಸೂರಲ್ಲಿ ಇವೆಲ್ಲವೂ ಮಾಡ್ತಾಯಿದ್ದೀರಾ ಅಂತ ಕೇಳಿ ಸಂತೋಷ ಆಗಿದೆ. ನಿಮ್ಮೆಲ್ರಿಗೂ ಒಳ್ಳೆಯದಾಗಲಿ. ಮಧ್ಯದಲ್ಲಿ ಆಪ್ರೇಷನ್ ಮಧ್ಯದಲ್ಲಿ ಮಧ್ಯೆ ಬ್ರೇಕ್ ತೊಗೊಂಡು ನಾವೆಲ್ಲರೂ ಕೂತಿದ್ದೀವಿ. ಮತ್ತೊಮ್ಮೆ ಎಲ್ರಿಗೂ ಶುಭಾಶಯ ಹೇಳ್ತಾ, ಪ್ರೆಸ್ ಕ್ಲಬ್ಬಲ್ಲಿ ಒಂದು ಡಾಕ್ಟರ್ಸ್ ಒಂದು ಫೆಲಿಸಿಟೇಷನ್ ಪ್ರೋಗ್ರಾಮ್ ಇದೆ. ಆ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ನಾನು ಹೋಗಬೇಕಾಗಿದೆ. ಎಲ್ರಿಗೂ ಮತ್ತೊಮ್ಮೆ ಶುಭಾಶಯ ಹೇಳ್ತೇನೆ. ಎಲ್ರಿಗೂ ವಂದನೆಗಳು. ಥ್ಯಾಂಕ್ ಯು ಆಲ್.
Thank you for your kind words, sir. Now I would request Dr. Ravindranath to felicitate MLA, sir. And Dr. Mahesha to hand over the mementos. Thank you for your gracious presence, sir. And I would request Dr. Ravindranath to lead for a cake cut since it's a Doctor Day, sir. I would request all the doctors to join for the cake cut. So.
Arab दादा देखो ये जो ना जो कैमरास में there are some cameras which will not, they are not able to adjust the cavity देखो तो वो ना so then it's not a good camera or I always work here this part of the phlegm which is in the midline it will always bleed तो पहले से थोड़ा ये कर लो ना तो things are okay for you curate दे दो देखो ना ये क्या हो रहा है के बीच में ये से जा रहा है ना तो विजन हाँ अंधेरा हो जाता हाँ हाँ इसके लिए तो देखो ये देखो ये विजन होना चाहिए ऑल द टाइम सो व्हाट हैपेंस लाइक ठीक है चलो कैरिसन दो इसका फेसेट बहुत बड़ा है सो वी जस्ट हैव टू वर्क ऑन द फेसेट ये जो कैरिसन है ना, इसके पीछे ना इज ऑल्सो वेरी यूनिक. तो ये फटाफट अंदर घुस जाता है. देखो, इफ द पीच इज थिक देन इट विल नॉट गो इनसाइड. लोकल में ना ये एरिया में पेशेंट को पेन होता है. पूरा स्कोप निकालो इसमें. आरफ दे दो. ग्रास बर्फ. कैसे समझोगे? Aradha? Yes, sir. Drill there. Aradha. RF to RF. RF. Guys, RF. કટ છે ને કટ યુઝ કરો તો બોન ઉપર બ્લીડિંગ કંટ્રોલ થઈ જાય બોન બ્લીડિંગ બી બંધ થઈ જાય कैसे અચ્છા કેમેરા બકવાસ છે એકદમ છે ને આ તો આપણે છે ને એક્સપિરિયન્સ એટલે કરી શકીએ છીએ બાકી અધરવાઇઝ નાનું હોય ને ના ના એટલે તો સ્ટોર સ્ટ્રાઇકરની એટલી ડિમાન્ડ છે ને યાર કે તે હેવ એક્સલન્ટ ઇમેજ ને તો અત્યારે છે ને આમ ઘણું બધું આપણે કન્વિન્સ બી ના કરી શકીએ આમાં હા ફોરકે પણ છે એ જ કહું છું કે જો અત્યારે કેટલી તકલીફ પડે છે મને હતું કે આ લોકો પાસે સિસ્ટમ સારી હશે પણ નથી સારી છેલ્લે તો ચાઇનીઝ ને हाँ अंकित कैमरा है ना ये बहुत अच्छा नहीं है फ्लेवर भी मान मान देखा से फ्लूइड का थोड़ा ऊपर करो आप एक्सपोजर सरस થઈ ગયું છે એટલે વાંધો નથી अपने पास कैमरा कौन सा है कैन वी चेंज द कैमरा कौन सा है अपने पास हॉस्पिटल में कौन सा हॉस्पिटल में कैंसर call Ankit since we have a time so like Ankit ये अपना कैमरा चेंज कर लेना है, बिकॉज यू सी क्या हम डेमोन्स्ट्रेट करके क्या दिखाएंगे इसमें. आई एम नॉट कंफर्टेबल. लाइक सी सर्जरी हम कर लेंगे, लेकिन फॉर એટલે કેમેરો છે ને, કેમેરો એટલો સારો નથી યાર. हाँ कुछ सेटिंग करो ना कुछ. हाँ देखो अदक अभी मैंने ब्लीडिंग भी स्टॉप कर दिया है. अदरवाइज इमेज इज सो क्लियर.
बाजू में क्या कैमरा ट्राई करो.
ठीक है, लेट देम चेक. अदरवाइज मैं यहाँ से जूम इन जूम आउट भी करता हूँ. जूम क्या है, यहाँ से भी फोकस कर रहा हूँ, लेकिन ये क्या, ये डेमोन्स्ट्रेट करना है तो द थिंग शुड बी वेरी क्लियर. एक काम करो, दूसरा कैमरा तो मंगा लो. क्या हुआ? नहीं ये चाइनीज कैमरा है. तो चाइनीज देखो, ये यहाँ से दिखना चाहिए ना. और इसमें ना क्या कि इसमें पानी नहीं जाता, बिकॉज हम ऐसे है. ट्रांसफॉर्मर में पानी जाता है, तो आई नो दिस. लेकिन अगर अच्छा है तो हम अच्छा दिखा पाएंगे. अदरवाइज क्या होगा कि लाइक केस तो हो जाएगा, बट द डॉक्टर्स विल नॉट कन्विंस. देखो ये यहाँ पे भी ना, ये इट शुड बी क्रिस्टल क्लियर. हाँ इसका सुनो भैया, इसका है ना इसका जो इमेज का जो क्लियरिटी है ना, वो नहीं है. चल तब तक RF दे दे. RF ये थोड़ा अच्छा हुआ ये. सी दिस इज लिटिल बेटर. हाँ चलो बताओ. कैमरा तो शिफ्ट कर ही लो, कैमरा शिफ्ट कर लो, उसमें टाइम नहीं लगेगा. और ये इमेज वहाँ जा रहा है, तो ये इसको वहाँ पे डाल देंगे. बिकॉज यू सी आई जस्ट वांटेड टू शो दिस हाउ वी सेपरेट द फ्लेवम, विच इज़ अ वेरी इम्पोर्टेंट. तुम अंकित कौन सा कैमरा यूज करते हो?
हेलो
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 हेलो. यस रविंद्र.
Yes, Siraj, what's happening?
Yeah.
We're having some trouble with the camera, I believe.
Yeah. So like you see, camera is not very clear. It's okay now, little okay now.
Yeah.
But you see, I just want. This is a very important step. We
Okay.
just have done the more of the bone work.
Okay.
But I just want to show that how exactly we remove the phlegm.
Yeah.
So I'm just asking if we have any another camera.
Okay.
So just changing the setting.
We had 3 cameras yesterday. I think one camera has been taken back, I believe. We have one more, hospitals, that can be used.
Yeah. So they're bringing the striker camera.
Okay.
Otherwise, how much? How clear is the picture? Let us see. If it is clear, if it is at least people can appreciate, then I can just go ahead.
Yeah, it is okay. I think a little bit of oozing is the one which is.
No. You see. This
yeah, now it is clear. Now it is clear.
Yeah. Okay. The oozing is okay. I can
Yeah,
control,
that is the one which is
but
creating
normally the picture is much more clear.
Yes, I think you need to fine tune the camera a little because, yeah, you can just fine tune it. The inverted V is little blurred.
So guy is already here.
Hmm.
He is working with the setting. This is little better. Because you see, this is the most important step.
Yeah, the V is not sharp.
Yeah, that is what.
Yeah.
So normally, otherwise it's very sharp. And see what happens when we go inside. So also the picture becomes very dark. So like you you work in the. Yeah, now something is better. Yes.
Yeah, relatively better.
Yeah. So Ankit is doing all the job. So carry some there. No,
We have
it's not sharp like. See, they have striker camera, so the striker will be much better. Even not even simple HD camera will also work.
Now we have striker there. I think Bhupesh is taking that camera, I believe.
Okay, so now you see, you can see now this is the edge of the phlegm. So
Okay.
you have to remove the lamina till you find the edge of the phlegm. And then what exactly we do, we use we have very special curette. Okay, show me the curette. I think this is okay. Wait. Abhi kuch. So you see, with the curette, we just go inside, we just make sure, and then I'll just remove this small part of the lamina here, and then I will just use the curette to elevate the phlegm. Give me Carison. So you don't have to struggle with small piece of phlegm. Okay, one more bite. So again, 3 o'clock is upper lamina, 6 o'clock is lateral canal, and 9 o'clock is lower part. So I have not still done anything with the lower part, but usually most of the patient, if you just clear the upper and the lateral part of the phlegm, you just use the curette to elevate the phlegm, and the phlegm will just got separate out. So same is with the midline. So now I just want to show this is the most important step. So you can see this is a 70-degree curette.
Okay.
Okay. So this curette will go inside. So I'll just put it inside, and then just separate the phlegm from the dorsal surface of lamina, and then you see I'm rotating. So this is on the midline. Okay. So my traction. So you can see this is little, you have to be careful that you don't catch, but you can see how nicely you are able to lift the phlegm even from all the side.
Okay, that's good. That's nice.
Okay, so this is the most important step, because you see now you have detached the phlegm from all the side. You see, okay. So now I will again check from the lateral side. So this definitely this is completely separated. Now you just have to use the Carison and take out. So like I don't like to use the sharp instrument, especially for the stenosis. So now let me just remove some of the phlegm, then we'll be able to appreciate the more structure. अच्छा दिख रहा है, गुड. स्क्रीन का प्रॉब्लम है. ओके फाइन. Give it accurate again. So now I will, we have done it from the midline. Now we will go on the lateral side. So again, like this, go inside, and now rotate the curate, and this is on the lateral side. Okay.
So this you are taking it from under the facet?
Yeah. No, this is the more of a central phlegm, and now you can see the code.
Yeah, yes.
Okay.
Yes.
So this will just so you see what happens. The phlegm is quite adherent. So if you do this, it will get separated from the dura also, and at the same time, you don't have to go and keep on taking a very small bite, because then your job is become very hectic. So now you see what you do. Do the traction. You can take out.
Okay.
The good pieces. Okay. So once I remove this, the picture will be much more clear. The dura will be seen nicely, and then we'll work on the lateral part, where we'll be able to do the more of a. So now you see, you can see that the phlegm is quite thick, and definitely working on this phlegm is going to relieve the patient's symptoms, because this is not a normal phlegm. This is quite hypertrophied. So again, you have to find out the right space where you can hold the phlegm. So see what I do, I go find out, then I give a little traction, then I just try to hold as much as the bulk of the phlegm, and then just pulling it out, not cutting. So the instrument is actually holding the phlegm, not cutting. And see, this is like a post-surgery patient, so definitely there will be some previous surgical adhesions and everything will be there.
Yeah, to the delegates regarding the dissection, cadaver dissection, we have made 4 groups, and all groups have been shared in your in the WhatsApp group. Please go through that and see which group you belong. First 2 groups, I think they can go for lunch at around 12:30. And once they are finished, then we will transport you to the hall. And after that, the 3rd and 4th groups also can go for lunch, and then we transport you again to the hall. So please check yourself. And first 2 groups, I think 12:30, they can go proceed for lunch. Restaurant. Yeah. Anyone else is missing out being in the group, just let me know, because only one or a couple of them maybe.
Okay, Ravindra, this white structure, what you see at the 6 o'clock.
Yeah.
It's SAP.
Okay, okay.
So you, once I do this, I will just cut the SAP also till I will find the lateral part of the root, and then from where you can do the dissectomy also.
So this is on the contralateral side?
Hmm?
You are doing this on the contralateral side? How is it?
No, this is ipsilateral side.
Ipsilateral. Can the image be a little more sharper?
So now you see we are able to expose the dura. So always try to hold the phlegm from the waist and just try to twist. So you see, you will be able to take out the big piece. So you can see this is, we are just trying to separate the phlegm and stretch out, not the cut. Okay, so see this is a SAP. So now this lateral phlegm will always go with small piece of SAP. Now you can see the root here. Now we are exposing the lateral canal. So here you will find the most severe adhesions and everything. So decompressing this area is going to help your patient a lot. So this is all we are removing the bone. So this is the lower lamina. So you literally have to train your hands for this control pressure, because you are cutting the bone, and at the same time you have to adjust the depth of the instrument. So now I am coming up to the upper lamina also, and I will just do the remaining job for the phlegm. So you see, lateral part of the phlegm you always try to remove with a piece of bone, so it will otherwise it will not come out. So you have to strip it. You can see the stripping is going to help, and it is going to take care more of the volume.
Shiraj,
Yeah.
we'll continue with your surgery, but we will finish one talk in between, and
Sure,
your
sure.
video will play here.
Yeah.
If you have anything, you can interrupt.
Yeah, fine.
Huh?
Okay, Mr.
Okay, yeah.
Thank you. Yeah.
Yeah. I invite Dr. Lavkush Pandey to give his talk. It was supposed to be given yesterday, but for some reasons he could not arrive here yesterday. His talk is going to about complications in transfemoral endoscopy and how we're going to manage them. Dr. Lavkush Pandey is from Dehradun, and he is an anesthetist and orthopedic surgeon. So he did anesthesia first, then he fell in love with spine endoscopy and some legal issues or say, so he wanted to become a surgeon also. And he went back and did his orthopedics, and now he's both an anesthetist as well as a surgeon. And he conducts many workshops. I have attended many of his workshops. That's almost 7, 8 years, Lavkush? Yeah. 2014, yes, almost 10 years now. Yeah, over to you.
Fit આવી ગઈ ને એટલે
They have this ceramic tank. So you know, initially we do the metals. What I can use the RF energy, convert it now with the step. Ceramic.
since the patient is GM છે ને એટલે બહુ okay, otherwise this point patient will yell like anything.
Hello. Good afternoon, everyone. I am Dr. Lavkush and practicing pain and spine endoscopy for last 9 years. And I will just correct to Dr. Ravindra. I just completed my DAY-2, but exam is still due. So next time whenever we meet, I think by the time I become a surgeon also. So I'm just talking about complications during transfemoral endoscopic surgeries, and I have encountered with many, and somehow I manage them, most of them. This is our conference workshop we are organizing for last many years in Dehradun in combination in association with Jolly Grant Medical College. So when we talk about the complications, for last 7-8 years, around hundreds of surgeons learn spine endoscopy from Dehradun, but only 15 to 20% are practicing and 80% already left this technique. So maybe because of these complications are related to this, and many of us sitting here must have, few of us visited to Dehradun also. The factors contributing to the complications during surgery could be patient related or surgeon related or surgery related. When we choose a patient, we always take care of and get the assessment of all the patient about any comorbidities, patient with diabetes mellitus, hypertension, hyperthyroidism, obesity, and their lifestyles, short stature, long stature, obese, and their nutritional status. When you operate a obese patient and next day you are operating a 30 kg patient, then your orientation will change, because you are making an angulation 30 degree in obese patient and 30 degree in an emaciated patient can needle land in both the cases in different places. So you have to collate during surgeries, keep in the mind according to the structure body of the patient, you can make the distance from the midline and angulation according to the patient's stature. And the complications related to the surgeons could be inexperience, and wrong diagnosis, faulty instruments using basic substandard instruments, unqualified sterilization. It is a quite common in when we start our early cases, and early learning curve. The complications generally encountered during surgery, these are immediate complications like injury to the neural structures, vascular structures, missed fragments that lead to the failure of the surgery, perforation of peritoneal sac or abdominal organs that very rarely until unless you are trained and qualified enough, and instrument breakage. Then the within the 24 to 48 hours, the early complications could be psoas hematoma, dysthesia, common formation, cyst formation, infections, and abscesses. And delayed complications just after 2 to 3 weeks to months, then could be a recurrence or instability to the patients. The severest and the less common complications, I haven't seen any permanent perioperative death during surgery, permanent neural damage, intra-abdominal organ injury or ureteric injuries, colonic ruptures and aortic ruptures. But these are documented in studies. The most common complications we encountered are intraoperative bleeding, postoperative hematoma, infections, transient paresthesia, dural tear, recurrence, headache, breakage of instruments, and missed fragment that lead to failure of surgery. Most of the complication already been discussed in our earlier talks. The intraoperative bleeding and postoperative hematoma, this is a common and most annoying injury to the sleeve just because of the injury to the intervertebral plexus, cancellous bones. And when we are working towards the upper part of the forearm, and the chances of bleeding is quite possible. So to control these bleedings, we use bipolar radiofrequency coagulations, increase the irrigation pressure, or still you are not getting control, you take out the scope, put the dilator and wait for 2-3 minutes and then go again, and check also the vitals of the patient if they are within permissible limit or not. The post-operative hematoma is rare but may present with inguinal pain or reticular pain, and injury to the segmental artery may be the cause if you are working more towards the upper part of the foramen. And small hematoma of less than around 50-60 ml can be managed conservatively, and larger need a surgical evacuation. I never have been needed as operative evacuation. The transient paresthesia is quite common because when we are putting our needle, our dilator, our guide wire, and we work around the DRG. So neural irritation can lead to the paresthesia post-operatively. The post-operative dysesthesia, motor weakness, very rare. During needling and placement of cannula, compression of working cannula to the exiting nerve root, injury to the furcal nerves, and more common in L5-S1 because of the high iliac crest. The risk factors like reduced foraminal height, foraminal or extraforaminal disc fragments, wrong placement of cannula, and mostly recover with after several weeks. The infection and spondylodiscitis is common in early learning phase of the spine endoscopy. It generally varies from 1 to 4% from different surgeon to different. In my cases, it's around 0.5 to 0.6% patients have been described. I have around 5 cases in my 700-800 endoscopic surgeries. It can occur it's generally less compared to the open surgery because in internal minor cases, I have never encountered any patient with discitis. Occurrence generally after 2 to 4 weeks. Patient complains about the back pain, fever, raised ESR, CRP, procalcitonin levels. The risk factors could be comorbidities like diabetes, uncontrolled diabetes, and prolonged operative time. Operative time is directly proportional to the chances of discitis because in earlier cases when we started endoscopy, our cases used to take around 2.5 to 3 hours because that was my early learning phase. The
chances of discitis were more that time. But now we are more conscious. We complete our surgery in 45-30 minutes. Risk factors and unqualified sterilization. Generally, we have scopes, cords. We keep them in the Sidex. Now we have improved our sterilization with ETO and plasma. So the chances of, with good sterilization, the chances of discitis are decreasing. And repeated needling and intestinal puncture or any abdominal organ puncture, and then again you go into the disc, that may lead to the discitis. And one thing I earlier noticed, the main causes I encountered after taking all precaution measures, the RF probe and your primary needle, they are the more culprit for the discitis. Because earlier I used to puncture the skin direct to the needle. So the tags of the skin, generally micro size of skin tags, go into the disc along with the needle. So later I started doing, put a nick over the skin, then I go my needle through this. And change your needles frequently, get it sterilized, autoclaved, sterilized or ETOs. Don't use more than 2-3 cases. Many times I have seen people are using their needles for 15-20 cases. So by the time rust and everything can lead. And another RF probe. We should frequently change our RF probe. 4-5 cases is enough. Don't try to use till the RF probe get distorted. Because the rust you can see, when you do the surgery, you can see the tip. There is you can easily see the rust over the tip of the, and this rust can cause a chemical discitis. The patient with discitis, generally we manage with rest, IV antibiotics for 2 to 4 weeks, third generation cephalosporin with gram-positive and gram-negative coverage, and open or endoscopic drainage if the patient have any motor involvement. So we go for the endoscopic drainage debridement and put patient on the antibiotic coverage. The recurrence, this is controversial to define as a complication. The diagnostic criteria is a remission of post-operative symptoms lasting for at least 2 to 3 weeks, MRI confirmation and reporting. The risk factors could include the end plate, osteochondritis, ruptured annulus, central herniation, or disc degenerations. Dural tear is very less common because we work on the angulation. Generally in early cases, you go 30-35 degree angulation into the disc, so chances of dural tear are very less. When we are later in future, we expertise this technique, we go more lateral, around 12 centimeter, 30 centimeter from midline, then chances of dural tear is quite common. Mostly asymptomatic, and it is generally, the incidence is less, but the occurrence is more than the reported cases because the minor dural tears generally unnoticed. The other factors can lead to adhesions. Earlier, second time surgery, earlier was microdiscectomy, and then next time you are performing the, then chances of, because of adhesions, the chances of dural tear quite possible. And as Dr. Mahesa said, mild to moderate can be managed conservatively. 2 mm, 3 mm, if you have root, you can see the root rate, but it's not coming out of the thecal sac. Then you can leave like this only or use a Duragen. If the rootlets are coming out of the thing, then you need to open dural repair. Headache and knuckle rigidity has already been discussed. About the pressure, how much pressure needed. As Dr. Mahesha said, I always use irrigation. I never use any irrigation pump. I do with under gravity. This can be managed conservatively. Low irrigation pressures, analgesics, and just head up of the patient. And the chances of this headache is quite common if the patient is getting their abdominal compression. So when you make a position, so if you are starting your early cases, I say you should take care of the patient from the beginning. Once they enter into the operation theater, you should make the position of patient your own and check everything, your abdomen is free. Because intra-abdominal pressure whenever is rises, then that can lead to the high epidural pressure, and then chances of headache and neck rigidity are more, and bleeding chances are more. Breakage of instruments, overuse, mental fatigue due to the metal fatigue due to the over repetitive use and substandard instruments, generally mostly guide wire, burr, forceps and dilator tips. Proper operation and maintenance care of can avoid it. Earlier when I was started my endoscopic journey, then I was taking care of all my instrument, my own only. Whenever surgery finishes, I take out the scope and take that scope along with me only. Never left my scope to my assistants. That's why still the first scope is still working. Now it's the backup scope, because I have the Maxer. That time Germany Maxer company was there. Then I bought that 3.75 working channel Maxer and transformer endoscope, and it's still with me. Can be removed under. Once I had encountered when my dilator tip was broken into the discal space, then somehow we take out through the endoscopy way only, and rarely need any open surgeries for the removal of breakage of instrument. The breakage of instrument common is with the RF tip, forceps, hook. Hook is quite common because we think we work along against the strength of the hook. We make a 90-degree of this hook and we try to pull against the bony structure. So you should know the strength of your instruments, how much force you can apply. The chances of hook breakage and RF tip is quite common. How to avoid complications? Failures are common in early learning curve. Outcome improves with experience and guidance. Follow up your teachers, whatever the instructions you are taking from here. And continuous learning. Take expert advice from masters prior to proceed to early and difficult cases. Follow the rules and protocol you learn. Always start your cases with proper lining and proper local anesthesia, then entry, do your cases. If you are doing transformer, do under local, never try to general anesthesia or any kind. And patient is your best monitor. Case selection, you should be knowing your caliber, which kind of cases you should take in your early period. And perioperative planning, discuss with your colleagues, never compromise on sterility. Listen to patient. Patient is your always best monitor.
Lavkush, yeah, I'll just stop you for a moment. Sorry. The OT, they want to show something very urgent. We'll just have a look at it and then again we'll start. Yeah, yes, sure, Raj, go ahead.
Lavkush, sorry to interrupt you, but you see, this is what we are talking about. This is the root retractor. So we have retracted the root, and then this is a special the knife which will go through the root retractor. So now you can, you must have seen that I just have done the small nick, cruciate shape, give me grasper. So I just did a small nick and the disc has come out. So now under vision, and you are very sure about the other part also, so you can do the discectomy also. So this is the one good advantage with using this bigger system, that everything is under control, and then you can just go inside and you can just take out the remaining pieces of the disc. And then you can do the annuloplasty. So you can see this is another piece. So you can do the annuloplasty also. So this is something very new innovation, which is very helpful to do the discectomy classically under the vision. So you see, like I don't have to put the sleeve. Sleeve is outside. This is the sleeve and this is the root retractor. So through the root retractor, and you saw the how I put it here at the scope. So you can see again, I just take it out again. So this is the root, okay. So I can just put like this.
So your instrument goes through the
scope, yes.
Goes through the scope, okay,
yes.
fine.
And now you can see, you can just do the. So even you can do a little traction and you can do the rest of the job. So this is what I wanted to show. I think we discussed the same thing about in my lecture.
Okay.
So now you can just do the more discectomy, and the good thing about this also is you can now seal the defect also. So now at the end you can do the annuloplasty. Fine. I think now Lavkush, you can continue.
Thank you. Thank you.
Yeah. Okay. Thank you.
Precaution is the always best policy, and you should take care of the patient during positioning, needle entry, and take care of neural, vascular, abdominal organ injuries, cannula during cannula placement, and during discectomy, graving the fragment, bipolar probing, irrigation, incomplete removal of fragment. These are the things you should take care during your endoscopic surgeries, earlier cases. Thank you. Any questions?
About discitis, how do you manage? I mean,
Discitis management first start with confirmation of diagnosis. So first, I will go for the our laboratory parameters to get the level of ESR, CRP, procalcitonin level, and the symptom of the patient they are correlating with not. First, I give a 1 week conservative trial. If the patient is still not improving, the pain is still rising, then I will go again recheck after 1 week or 10 days the ESR and CRP level, and they are also rising along with the symptoms. They are still rising, then I will start IV antibiotics like generally ceftriaxone and linezolid. I have given these 2 antibiotics only, and one of my senior surgeon, I always take advice from him, Dr. Mahesh Kuria. He always gave rifampicin, but it always worked. I don't know why it worked. Like it's a gram positive, provides some gram positive coverage, but the oral rifampicin along with IV ceftriaxone or piperacillin tazobactam along with linezolid for 2 to 3 weeks continuous proper doses, and then later shift the patient into the oral. If it's still not improving, we go for the MRI and correlate with the MRI.
So you prefer to do an endoscopy lavage, go back and again try to
No, because patient never agrees for the second time and putting your needle and cannula, because uske dimag mein he always think if first time he did this and my pain also already increases, second time I don't know what will happen. But patient is having a motor weakness, then he agrees, then we go for the in tubercular cases I have done in 2 or 3 cases lavage and then put on the ATT.
Yeah, this could be in discitis. I mean, our experience says that whenever either open or endoscopic, if we face discitis, so we can always go back and with the same route we can give a lavage 2 to 3 liters and mixed with gentamicin and all, then supplement with IV antibiotics. It takes away a big load of infection from the disc. So after doing that, in spite of that, the infection continues, then the next alternative of either a fusion or whatever you can decide. Thank you, Lakush.
Okay.
Thank you
Thank you,
for
sir.
your nice talk. Thank you. Sir, I had 4 cases of discitis in my practice. So the first one was a chemical discitis. Chemical discitis because I was not aware of that. Maybe I could use my instruments putting in Cydex that time, long back, 10 years back. And it was not correlating. I mean, his findings, the blood tests and the symptoms were not correlating. So we managed him and over a period of time, 2 to 3 weeks time, he recovered. I did not give him any IV antibiotics or anything like that. But second case was a diabetic. So this patient we did a lavage, but then he didn't improve, so we had to go for fusion. 2 cases in fact. The last one, of course, he responded, young fellow. So we gave a lavage and IV antibiotics, he did well. So it's very difficult to say who will respond and not. But then maybe comorbidities, if somebody is a diabetic, uncontrolled, then it may not.
In case of discitis, I have a very good experience that when I started my journey in 2017, I got near about 7 or 8 cases out of 500, initial my 500 cases. Then I started to, and all cases presented in a month of August 2018. Then I started to search the bacteria. All things were negative in my operation theater. Then I searched the bacteria in the SIDEX tray. And the SIDEX tray culture was positive. And I immediately replaced the SIDEX tray with the ETO. Since then, I didn't have a single case of the discitis. So I think it's all depends on our management. And the one more thing, when the floor guys, generally floor guys just take the bottles. So always keep the, just clean the surface of the bottle like the some sprit and the stellium, then ask to prick with the sterile needle. These are the little things to prevent the discitis or the infection. Thank you so much.
Now E2O machines are not so expensive. They are coming in the same price. You give a good autoclave.
The discitis do very well with the endoscopic lavage provided you do it early. The problem is if you do it late and already there is end plate damage, the infection may resolve but patient will continue to have severe back pain because of end plate damage. So those cases you will have to do a fusion. But if you pick them early and do endoscopic lavage, they do very well. Very well. And the most important thing is to pick the bacteria. So that's why if I see a discitis, I don't rush with the antibiotics. I just do endoscopic lavage, take biopsy, culture, get the organism. Once you get the organism, these antibiotics works very well after lavage. Before lavage, they may not work. But once you give a lavage, debride and clean, they do extremely well with the antibiotics and conservative treatment. So key is to pick them early and treat them early.
Oh. Thank you. I just invite you to our next workshop in Dehradun in December first week. All of you are most welcome. Thank you.
Okay, we break for lunch now. I think the first two groups we had, as I mentioned. So the delegates who are belonging to those two groups should go to the restaurant now, finish your lunch, and we arrange the transport. So then we'll shift you to the cadaver dissection hall. Okay. After 10 minutes, it's in the third and fourth groups. We'll go to the restaurant. We'll just give that. Let's start for the first two groups so that there will not be any congestion there. Okay. Yeah.
Comment on discitis. MRI allows us an opportunity to probably look at discitis in two groups. One in which, in the T1 weighted images, the adjacent vertebra is completely black. These are the few ones who are probably infected. Congrats. So I just wanted your opinion if you have observed this difference. There are some discitis where the adjacent vertebra is completely, which is white on stir images and dark on T1 weighted images. Okay. There are some discitis where there is a clear-cut line across the vertebra where only one half or the adjacent to the disc plate is inflamed and the rest is uninflamed. And most of them fall into the second category. And I believe there's a cellular basis for the second kind of discitis and not an infective basis.
Sometimes I feel it is the duration of pathology also, because for the first 2 weeks you will not see MRI changes unless you give a contrast. Initial 2 weeks of discitis, if you do it early, you will not see changes because end plate changes come only after 10 to 15 days. Initial 10 to 15 days, if you do MRI, you will not pick up changes. Patient will have pain. But if you do MRI in the early stage, it will not show anything unless you do a contrast MRI, which may show increased uptake.
I would like to add one comment. It is my routine practice to do a CRP and ESR pre-operatively, because it happens many times that many patients, especially the female, they had a lot of UTI and the other things, and if the patient is presenting the low back pain after the surgery, always we hit with the discitis. And when you go first time with the ESR, CRP and the other markers, and if it is raised, then definitely you will think that it is the discitis. So it is my routine practice, and for the endoscopic surgeons, I would suggest to go for the ESR and CRP before surgery as a baseline.
After surgery, it will rise. It will rise. So you have to see clinically at the end of the day. Yeah. Yeah. Okay. This is Shiraj, are you going to do opposite side? Hello?
Because soon we are going to start with the
Hello?
research.
Okay, can you hear us?
Yeah, Mahesh, I can hear you.
Yeah.
So we have shifted the entire camera and everything to the other side.
Okay.
So I have enough time, so I will just do the opposite side also.
Okay.
But you will not be able to see because the camera is shifted.
Okay.
Yeah. So right now you'll be just able to see the picture of the camera.
Okay.
Okay.
Yeah.
Okay. अंकित करना है बायलेटरल कर देना है ऑपोजिट साइड करना है ऑपोजिट साइड हाँ
Hello, Bhupesh. Hello. Hello.
नहीं तो इवन है ना इवन यूनिलेटरल डिकम्प्रेशन इवन जो माइल्ड बायलेटरल जो दूसरी साइड का होता है ना वो भी रिलीव कर देते हैं करना तो कर देते हैं मुझे ना ये कैमरे में बिल्कुल मज़ा नहीं आ रहा लाइक आई एम नॉट हैप्पी चल लाओ ये देता बाकी अपने पास कैमरा है कैसा है कैमरा से हम दोनों और 4K में तो क्या दिखता है हम अभी काफ़ी ऊपर आ गए हैं लाइक वे क्वाइट अप सो आई जस्ट वांट टू लाइक क्लियर दिस मोर एंड सी and this is absolutely I have closed all the channels so this is not related to the bleeding चलो freer दे दो check so you see this is the disc area और हम यहाँ पे we have already reached here एक करेक्शन दे दो okay transforaminal you don't need the very good camera you are okay with any camera but interlaminar में like you don't enjoy the चल आरएफ दे दो थोड़ा नहीं ये ना एक्चुअली व्हाट इज हैपनिंग दिस कैमरा इट्स नॉट एबल टू टेक
Ready? Hello.
Hi, Bhupesh. We can hear you.
Yeah, sir. We just prepared the patient, and just show us the MRI.
Okay. You got everything you wanted?
Yeah, we got almost everything, yeah. So he's 45 gentleman with right foot drop and bilateral leg pain.
Okay.
Right is more than left.
Freer than?
But he is not able to walk because of severe pain.
Okay.
If you see the MRI, severe stenosis with herniation at L4-5 level. There is also stenosis at L3-4 level, but we are doing primarily surgery at L4-5 level right now.
Okay.
If we get time, we will also do L4.
Okay.
But our primary focus is L4-5. We'll start from L4-5 spinal lamina junction on left side. We do contralateral de-roofing with drill system. We remove the flavum and we do decompression on both sides. This is our primary plan.
Okay.
And I have, you can see the MRI?
Yes, we can see.
Okay. So now focus here.
Yeah.
I have taken the portal. Each patient is little bit of kyphotic. This is our midline. You can see?
Yeah, we can see.
Yeah. And this is our scopic portal. You see the lower border of pedicle.
Yeah.
You see now?
Yeah.
Yeah. And this is our working portal, mid pedicle of lower vertebrae.
Yeah, we can
okay?
see. Yeah.
And this is our angulation towards the spinal lamina junction. Just show us. You see?
Yeah.
Yeah, base of spinous process, and both are converging.
Yeah.
Like this.
Yeah.
Okay. So now with this instrument, I'll just go in and just do little bit of just shoot. Okay. This is a, so just deburr the lamina, deroof the lamina, so that our both port are equal. So give me the last instrument and these two things. No, and this one. Okay, no. एक मिनट मैडम, इसके अंदर एक था ब्लंट, एक था डायल्यूटर था. Okay, चलेगा. So with these two instruments, show. Yeah, you can see now on the base. So we do like this kind of movement to merge to port just below the multifidus muscle and this, so that our port become very free. Okay?
Okay. Yeah.
Now I'll start my scopy. Before that, I'll just put a small retractor system. It's made by Manman.
Okay.
Just to retract the soft tissue in case any soft tissue comes in the way.
Patient has
कैसे रहेगा ये?
narrow canal.
सिर्फ साइकिल का ही है ना? वो यहाँ मैच करना पड़ेगा. एक मिनट. हाँ. हो गया ना? Now you see the free flow.
Yeah, we can see.
From working port. CM का height down कर दो. Table का height down कर दो. Sorry. हाँ, CM out. 1 minute. I forgot one more instruments. Oh, voila. Okay.
So this
is again a sleeve.
Shoulder sleeve.
So just show this.
Okay.
Just to retract the soft tissue.
Maybe it will help you to protect the scope also.
ये निकल जाता है यार इसका.
Bhupesh?
Huh?
It helps to protect the
Yeah.
scope also.
Yeah. Just to protect. down, ना up है. It has to come like this. अब एक मिनट हाँ. एक मिनट हाँ. Yeah. Now things are okay. इसको यहाँ से निकाल के उस तरफ ले लो. So we has to go down and little bit, give a time. चलो मैंने आरिफ दो. आरिफ शूट एक बार सियाम को शूट दिखा दो ना. या आरिफ का कहाँ है फुट स्विच. So the triangulation has come.
Yeah.
We just need to find the spinal or minor junction now. Shoot. एक मिनट. Okay. Now give me a foot switch. Foot switch of birth, yeah. नहीं हाँ एक में थोड़ा एक triangulation आ जाए ना.
So which is the probe you are using?
This is a bones probe.
Okay.
Now they have made a little change in the probe.
Okay. The camera is also from them?
1 minute.
Camera seems to be striker.
Yeah, camera is striker system.
Yeah.
But it just not, it just delocked. ये plug क्यों हो जा रहा है इसको?
These are stores arthroscope or?
Yeah, these are stores arthroscope. No, these are striker system.
No, the scope also striker.
Scope is striker.
Okay.
So now I am getting a triangulation. You see now?
Yeah, we can see the tip of the instrument.
So making an initial space is also one of the most challenging job.
Yes.
After that, surgeries are a little bit easy. because you are doing like same what you are doing only. So I'm just creating a space.
Can you orient on the endoscopy image 3 o'clock, 6 o'clock, and
Yeah.
9 and 12?
12 o'clock is midline.
Okay. Then
1 minute. Okay. Just need to.
you're standing on the right side?
Yeah. I'm left side on the patient.
Okay. But his foot drop is on the right side?
Yeah, but we do both side decompression.
Okay.
In UB, if you are right-sided surgeon, then you have to do on left side only.
Yeah, that is one issue
Only
with the
issue,
UB,
yeah.
which is not there with the interlaminar endoscopy.
Yeah. Otherwise, you have to be bidextrous. You need to work with both hand.
Yeah.
थोड़ा मुझे एक forceps दो, थोड़ा grasper दो. चलो चले RF दे दो अभी.
What we are seeing is the edge of the lamina?
Yeah,
Okay.
edge of lamina. थोड़ा RF बढ़ाना है तो RF बढ़े नहीं है नहीं कुछ. हाँ थोड़ा बढ़ा. Yeah, चलो लाओ शेव डिसेक्ट दो मुझे. हाँ फोर्सेप्स दो. चलो अभी RF दो.
So you are doing both UB and PSLD?
Sorry?
You are doing both PSLD and
Yeah.
UB. So what do you feel is better?
Yeah, if lumbar severe stenosis, I would prefer UB because your mobility is also good in UB.
Okay.
But yeah, in routine cases, 80 to 85% cases, I think PSLD is more than enough.
Okay. Is there any difference in time?
In?
The time required for each procedure?
I think both are same.
Okay.
Initially, UB take forceps दो मुझे. Initially, UB take little more time. It again
Okay.
depends on our learning curve.
No, once you pass the learning curve,
Yeah.
do you see any difference?
चलो RF.
Did you have any issue with the scope breakage or anything?
Yeah, sometime I broke my scope once time. एक वक्त सियाम खाली एक व्यू दिखा तो चलेगा. छोटा. चलो मैंने ड्रिल सिस्टम दे दो अभी. नीचे लगे, पहले ड्रिल करके देखते थोड़ा। उसका फुट स्विच कौन सा है? ओके Arif.
You're using striker bar.
Yeah, striker bar also. Not that much. एक वो स्लीव दो ना, 1 मिनट, वो वाला एक स्लीव होगा ना, छोटा स्लीव था ना पहले। यहाँ से क्यों निकल जाता है यार ये? I want to remove it from here only. Yeah, यहाँ रहना चाहिए। Okay. फोर्सेप्स तो मुझे आरिफ। ओके, चलो अभी आरिफ दो। So with that sleeve, I retract that now soft tissue.
Yes.
On my scopic portal.
Okay. Now you are working on lower lamina, na?
Yeah.
Okay.
No, now give me a bar. Bar. So now we are ready with drilling completely. पानी खत्म हो गया। अरे यार तू खड़ा हो क्या? सो गया क्या?
Bhupesh, using irrigation pump or?
No, I am not using any, only gravity assisted.
Okay. Any measures to avoid fogging in camera?
Fogging.
Hmm.
As I told you yesterday, today morning we had the RF
Yes,
discussion.
yes.
Just to avoid the fogging, most important is OT temperature is very important. Yeah. एक मिनट हाँ. Yeah. बर. Yeah, forward है या backward है? हाँ, ये forward है. ये forward है ना?
Bhupesh? Hello?
हाँ, yeah.
Any implication of clockwise rotation or anti-clockwise rotation?
Sorry?
Clockwise rotation or anti-clockwise?
Orientation?
Rotation of this your burr.
That's what I'm just saying. Forward or backward. थोड़ा 10,000 कर दो ना इसका speed, RPM. इसमें forward backward कहाँ है switch? No, it looks backward. This forward, yeah. It has to be forward, otherwise backward it will not work. Initially I was doing backward, that's why I'm getting trouble. Sorry.
I generally use backward for stop bleeding from the.
Okay. RF. Many times you can control the bleeding with the head of this RF because it's all a cancel spoon. CM ले लेना जब कहते थे CM डालो. Yeah.
Now you are in the base of the spinous process.
Yeah, right now I am in the base of spinous process. RF बोन एक्स भी ले लीजिए. हाँ, बोन एक्स भी लेके रखना. हाँ, सिस्टम मुझे दोनों पैर में मेरे आ जाए ठीक से ऐसे करो. दोनों पैर है ना. डील है ना. ये निकाल दो, इसको ये निकाल दो, ये बकेट निकाल दो. That is just चलेगा नीचे पानी पड़ेगा तो. So this patient has a very narrow interlaminar window. So I initially drill a bit just to get my orientation. Now I start deep drilling.
Okay.
Yeah, now you get the flavum and lamina junction.
Yes.
चलो मैंने RF आपको और RF दो थोड़ा. हाँ तो उसको बेस को हम ये दोनों है ना, मुझे ऐसा लगा मेरे पैर के सामने होने चाहिए, है ना सिस्टर? चलो ड्रिल. Arif. ड्रिल 150 क्यों इतना ज़्यादा है? हाँ चलो ड्रिल. Sorry? Yeah. I'll tell. Arif. So they have this bones. They came up with the new things. Hello.
Hello? Huh?
They have made this ceramic coated. Initially it was, metal coated. But what happened with metal? Sometime if we do on retract the root with the coat metal cannula and we do on contralateral work, sometime it's happened to be a nerve root touch with the spark.
Oh.
क्या हो गया यार, क्या है ये?
How much is the blood pressure of this patient?
So that it's एक बार सीएम दिखाओ ना, एक बार, एक मिनट, थोड़ा सीएम दिखा दे बेटा, एक बार आरिफ 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 दे, आरिफ दे। सॉरी, एक मिनट। हाँ, एक बार डिसेक्टर दो मुझे। चलेगा कोई, चलो शूट। ओके, आई एम टू मच ऑन माय साइड ना, अरे बीच में आओ यार। थोड़ा टिल्ट करो ना टेबल को मेरी तरफ। So we need to borrow more on, दिखाओ एक बार, kyphotic shoot. Okay, so this one we have to burr almost. चलो burr. आरिफ, चलो बर। पानी खत्म हो गया, क्या हुआ? तुम ध्यान रखो, हाँ, मुझे बताना नहीं चाहिए यार। आरिफ, चलो आरिफ आरिफ, क्या हुआ? क्यों ऐसे? ऊपर थे अभी तो। 4 RF बराबर है। हेलो
यस हाँ भूपेश
सब खाने चले गए क्या?
नहीं नहीं
हाँ
आई एम वाचिंग यू
अरे आरिफ કરી જ પડશે સાહેબ જુઓ તો ખરા એમઆરઆઈ જુઓ જુઓ એવું છે આવું કરવાનું ધક્કો મારી દેવાનો મેં કઈ નથી મને તો ખબર નથી કયો કેસ મારે કરવાનો હતો એ તો હા હા
भूपेश
हाँ सर
ask Shiraz to wash with you so then you can
Sorry?
Shiraz को भी अपने साथ में wash करा लो then you can easily
Yeah.
he can help you in assistance
यस नाउ हो गया कंट्रोल જવું છે રમો રમો हाँ बोन वैक्स है क्या? बोन वैक्स ले लो ना चलो ड्रिल दो मुझे
Krishnan work
आरिफ
Bhupesh, you start from the spinal laminar
Dissector.
line.
Dissector.
Bhupesh, Ajay here. Hello, Bhupesh.
Yes.
You start from this, Ajay here, Ajay Krishnan. You start
Yes.
from the spinal laminar line.
Yeah.
And go in an arc form.
Yeah.
And towards the facet.
Yeah.
Okay, so that is the only part you have right now burred. You have
Yeah.
not made an attempt to burr under the spinous process, neither an
Yeah.
attempt to burr the medial facet.
Yeah.
So that you want to do after exposing the canal.
Yeah. Sorry sir.
जो canal expose करना है अभी आप
हाँ।
expose कर रहे हो तो you don't want to burr the under surface of the spinous process early.
Yeah, I want to burr.
हाँ.
But you know, just because of bleeding, I'm
Okay.
confused. Now I start drilling spinal laminar junction only.
Okay. And
Little bit of, I was on more on my side. I
So-
has to be on medially.
So don't you use the diamond burr?
No. Diamond burr create lot of crust.
Crust?
And actually we don't have. We prefer many times, but we don't have here diamond.
Because
tip.
towards the end, if you use a diamond burr, it would help.
We can use, yeah.
You are bleeding because you are getting little bit of difficulty.
Actually, sir, what is there here? A patient at kyphotic spine, you know.
Okay, okay.
So our orientation is
a
more
bit
we are
different,
going more
yeah.
ventral, and the things are is more dorsal.
Yes, 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 yes. Okay.
So this is again because of kyphosis. I went more dorsal ventrally. चलो आरिफ आपको है ये हो रहा है आप समझ रहे हो ना
What is the BP, Bhupesh?
105.
Okay. Maybe because of the burr, because it is sharp, it is bleeding. So
It will go. I'll control bleeding.
Yeah,
It's no
but you have this weapon.
Only all are bony bleeding, so
Yeah.
nothing to worry. So now it clear? Okay, चलो बर देखो ये ले लो यहाँ से पूरा इसको यहाँ आने दो
Do you
और
do
इसको
all
ऐसे
bony
यहाँ
work
कर दो,
with
हाँ।
burr or you use subcutter also?
चलो आरिफ दो चलो दे दो ड्रिल दे दो
Bhupesh?
हाँ sir.
How many cases you can use this RF?
Sorry?
How many cases you can use this RF?
How many
Cases you can do with this one RF?
One RF.
Ah.
Around 10 cases.
Okay. And cost?
RF around it is around 15 to 16,000.
Okay.
Yeah. No RF नहीं चाहिए. Yeah. चल RF. जला गया. चलो भर दो मुझे. आरिफ दो पहले. नहीं मैडम यार ठीक से करके दे यार दोनों. एक ये पैर में दे दे. चलो बाहर दे दो अभी. नहीं पहनने, वो निकल उसको है ना, वो निकल जाते हैं शूज अपने. चलो. Okay. It's too thick lamina, na? But yeah. Arif.
Bhupesh?
Sir.
We will have to move to the cadaver session.
Okay.
So your surgery will continue here.
Okay.
So we will be taking a break for lunch and then moving to cadaver.
Yeah.
Huh? Okay.
Definitely.
Okay. Thank you for this demonstration.
Yeah, thank you.
So all the delegates, please go and have your lunch, and then the vehicle will be down to take you to the cadaver hall.
Okay, now it's beautiful. Give me bar of. हो गया, चलो. So now you can see, Dr. Mahesha.
Yes, we can see.
Yeah. Now this is a proper orientation.
Yeah.
Now you can see I am just burying the phlegm on contralateral side, and this is on my side.
Yeah. It's a very, very tight and
yeah, laminar window is very narrow. I have to
Yes.
create the window entire.
Yes, correct.
So that's why, and again a little bit of kyphosis, so I went little ahead.
Okay.
Didn't realize that.
I think some more lateral drilling may be required.
Yeah.
The facet.
चलो अभी भर दो.
Okay, Bhupesh, we'll
Yeah,
break
yeah, yeah.
from
You
here.
proceed.
Yeah.
I'll finish
okay.
it off.
Okay. Okay.
Bhupesh, how do you decide the endpoint of your burring on contralateral decompression? Where you stop? Bhupesh? Hello? Hello, Bhupesh? Is it not getting relayed? Voice, sound?
अभी भी उसी हॉस्पिटल में हो ना आप?
हाँ नहीं, CMI में मैं इंश्योरेंस के केस करता हूँ। मेरा अपना इंडिपेंडेंट सेंटर है, वहाँ पर डे केयर 2000 स्क्वायर फीट में 2 OPD है, एक बेड, 2 बेड्स हैं, OT है, फिजियोथेरेपी है और मेरा अपना OPD है।
ओके, वही करते हो?
तो
देखा था मैंने आपका पूरा एक ट्रेडिशनल होम था, वही?
हाँ,
घर था वही?
नहीं नहीं, वो तो बहुत पहले था, वो हॉस्पिटल घर जैसा हॉस्पिटल था।
हाँ,
शुरुआत में था, अब अलग है कोरोना के बाद से।
ओके।
तो वहाँ मैं 12 बजे जाता हूँ, 5 बजे तक रहता हूँ। तो जितने भी पेशेंट जो नॉन डिमांडिंग टाइप के होते हैं ना, उनका वहीं करता हूँ। जिनको 5 स्टार फैसिलिटी चाहिए होती है तो वहाँ CMI में करता हूँ। गांव वाले हमारे यहीं करा लेते हैं, उनको कोई 4 पैसे कम पड़ जाए तो वो कहीं यहीं कर लो।
सर्जरी चल रही है अभी।
Bhupesh, you are nearing to finish. Hello?
Hello?
हाँ, Bhupesh.
हाँ, yes sir.
We were asking कि what is the end point of your
Contralateral decompression. Yeah,
contralateral burring? When do you stop?
When we see, I stop burring when we see there is a cleft is seen in the midline during the burr. So once I see the cleft, I start burring contralateral side, and when contralateral side, you see that your instruments, supposedly this burr, it is going freely on opposite lamina. You see, till the lamina I burr, and I see the edge of phlegm also. If it is easily dissectable, supposedly I am just trying to put one instrument and this is a flaval edge. If I can reach beyond this edge, I stop burring. But main is guide is your cleft, intervertebral midline cleft.
Okay, okay. The most inferior most portion of the ligamentum flavum, juxtapedicular.
Yeah.
That portion in cases of the open surgeries with a part of the superior lamina we
So
remove.
here we also can remove very well. We'll see.
Yeah.
Because we need to see almost traversing nerve root till the pedicle.
Yes.
हाँ, हो गया अभी हो गया see, still there are some doctors are there. Dr. Ajay Krishnan is also there in a hall.
मैं भी हूँ भूपेश.
Yes, sir. So this is I am doing on contra. Hello.
Hello.
Yeah, sir. Are you listening me?
Yes, yes.
I am doing this a contralateral decompression.
Mm-hmm.
Sorry for a little delay because what happened, this patient has kyphotic deformity and interlaminar space was not there.
Yes.
So just to find the interlaminar space, it took a little more time. Chalo, dissector aap.
It's a 2 mm Carrison, na?
Yeah, 2 mm punch, yeah. चलो कैरिसन ये पानी के मन हो गया So now I'll just try to remove the disc from this side. Dissector दो मुझे. So you can see the disc here.
Yes. Bhupesh, you are using Carrison 90 degree or 45 degree for
45 degree Carrison.
For ipsilater also?
Yeah. Because this is, sir, I am using this 30 degree scope, Carrison. So you can get angle in ipsilateral also. If you are using 0 degree scope, then getting angle on ipsilateral side is difficult. RF. डिसेक्टर देन डिस्क फोर्सेप्स छुट्टा वाला एक कर्व डिस्क फोर्सेप रहेगा यू सॉ ना या दूसरा एक होगा एंगल वाला मेरा है आपका है ये मेरा है आपका है मेरा है आपका है माइन ना या यू सी द डिस्क नाउ
yes
I can retract with the root retractor but I don't want to you know इसको रिमूव कर सकते हैं हम अभी है ना इसको टिप को क्लीन करो। क्या करेंगे अभी? दूसरा दो चेंज करो थोड़ा ग्रेस्पर को। एक रूट डिटेक्टर होगा इस तरफ आओ, नहीं इस तरफ नजीक में नहीं 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 नहीं, इस अब जगह दो मुझे, थोड़ा जगह दो। ऐसा एल होगा एक, कहाँ गया? रिट्रैक्टर था वहाँ एक, ऐसे पकड़ने वाले था एक रिट्रैक्टर। इट वॉज देयर व्हेन वी आपने किया था। यहाँ नहीं है, नहीं इट वॉज देयर। अब मैंने आपको बताया नहीं था एक रिट्रैक्टर था। देखो मैडम, नहीं 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 नहीं, एक ऐसा था, मुझे देखने दो, उसमें कुछ रह गया ग्रीन ट्रे में। देखो एक इंस्ट्रूमेंट रह गया है, एंगल हम रूट डिटेक्ट बोलते हैं ना, ऐसा था एक, इसमें ही था। हाँ इट वॉज देयर हियर, आई बॉट इट हियर, आई नो इट। देखो वो था यहाँ, मुझे कैरिसन दो अभी 2 mm। एक एल डिटेक्टर था, 100% इट वॉज देयर। अब हम रूट डिटेक्ट करते हैं ना स्पाइन में, व्हाट वी डिटेक्ट द रूट डिटेक्टर इन द स्पाइन ना, इट वॉज लाइक सेम। आई कैन नॉट सी हियर। अब रूट डिटेक्टर जो है ना यूबी जो ने, है मिला क्या? नहीं नहीं मारा सेट में तो रिट्रैक्टर, नहीं नहीं हाँ एक एल डिटेक्टर हूँ लईने આવ્યો તો હમણાં જ મેં મૂક્યું છે, ભૂલી ગયો છે। એક મિનિટ દેખાતો બહુ મોટું પડશે આ સમજો। એંગલ નથી મળતું. બીજો बॉल टिप प्रोब आपने तो प्रोब છે स्पाइन में से प्रोब होगा एक बॉल टिप दिखाओ आपके स्पाइन इंस्ट्रूमेंट लेके आओ.
इधर
हेलो
तो भूपेश को अगर बोल.
हाँ सर.
Bhupesh,
Yes, sir. Any
wonderful demonstration. You are about to deliver the last thing, and it will get delivered.
It is just like, you know.
Yeah. It was a
third
tough
trimester.
case. At time it is like that, but it is just handista. Wonderfully demonstrated.
Yeah.
Everybody now need to rush to the JSS. We have waited.
Okay.
Good. Thank you so much.
Yeah, I'll just finish it in 15 minutes.
It won't take more than that, but now the bus is just going, so we have to rush now.
Okay, yeah.
Thank you so much. Thank you so much, Bhupesh.
जो दे फ्रेगमेंट आओ तो नहीं बाहर है. एक बॉल टिप हुक है ना. हाँ यस थैंक यू. सॉरी
भूपेश आप उधर आ रहे हैं बाद में और जेएसएस में.
यस यस आई विल कम.
ओके ठीक है. इधर डिस्क था थोड़ा.
हाँ
डिस्क था.
डिस्क है बड़ा है.
बड़ा है ठीक है.
बट आई यू नो एक रिट्रैक्टर नहीं मिल रहा है. हमने जो सुबह देखा था वो. आई एम जस्ट सर्चिंग फॉर द रिट्रैक्टर एंड इज अ वेरी बिग डिस्क हियर यू सी.
ओके ठीक है. बाद में
रिमूव इट इन 15-20 मिनट्स एंड विल जॉइन यू.
ओके.
Yeah, now you see. Okay, निकल गए सब. डिस्क फोर्सेप्स હવે આવી જવું જોઈએ યાર. ચૂટકે હે વિડિયો લે આટલો સરસ તો વિડિયો તું નહીં લે આનો.